Let's start. Hello, everyone, and welcome back to our YouTube channel. Today, we are doing something different. I'm not just going to teach you, I'm going to challenge you. We are going to become radiology detectives. Introduction. We are going to become radiology detectives. Our job is simple. As I told you, we will look at the things that look alike and we will find the critical clue to separate these things from each other. If you get it right, the patient lives. If it's wrong, the patient dies. So, this search protocol here. First, we will look at the abnormality. Where is it? We will look at the location, which compartment of brain. We will talk about brain now. We will look at the Hounsfield unit, the sequence signal on MRI. We will look at the enhancement pattern, and we will look at any associated findings, especially edema, the usual suspects. Let's look here. Look at these three enhanced rings or ring enhancement. They all look similar on a standard CT or MRI, but they are our usual suspects. The first big decision as a radiologist often starts by separating these three. One of these lesions is a glioblastoma, and one of them is an abscess, and one of them is a multiple sclerosis. If you look to the images, they are all cystic, ring enhancing, okay? And they are all intraaxial. So let's wait and see. The challenge case number one. This is a 45-year-old male patient. There is a sudden aphasia. He came to the emergency department. The emergency department said stroke. So they ordered MRI. What do we have? These are our first two images. We have a CT scan and an MRI. What do we see? On the left side, the CT scan, there is some hypodense lesion, while on the right side, on the MRI, it's very bright. This is a T2 axial image, okay? First of all, what kind of edema this is? Is it in the gray matter or white matter or both? And do you know which pattern this is? It's from our previous lecture of the brain edema. Which kind of edema is this? Excellent. The first thing, this is a vasogenic edema. Why it's vasogenic edema? As we said, because it involves the white matter, stops at the gray matter, and it is finger-like. You can see it's finger-like. Good. Let's look at the flare images. It's the core sequence. It's the main sequence. This is a flare. It confirms extensive vasogenic edema. But look inside that edema. There is a lesion that has a slightly different signal. This thing here. The signal is different from the edema. So, is it solid? Is it cystic? We don't know yet. We have to be extra sure. So, what's next step you would ask for? What's the next clue that you look for? In vasogenic edema, diffusion is negative. Exactly. Contrast. We need to give contrast. If we did the diffusion, it will be negative. Definitely. No need to do diffusion here because this is a vasogenic edema, not a cytotoxic edema. Got it? What do we have here? This is a T1 post-contrast. You asked for a contrast, and this is a post-contrast. Look at the enhancement. Is this thin, smooth, ring-like an abscess, for example? Is it a solid nodule? What kind of enhancement is that? Solid, ring, or nodule? Thick ring enhancement. Exactly. It's a thick-walled ring-enhancing lesion. Someone asked for a diffusion. This is the diffusion. As I said, this is vasogenic edema. So there will be no diffusion restriction. As you can see here, the edema is showing nothing on ADC, on diffusion, and it appears hyper intense on ADC, apparent diffusion coefficient. Sorry. This is the money shot, the big one. We can see that it's not only about the surrounding edema, it's about the lesion itself. Is the lesion itself showing diffusion restriction? Look inside the lesion. Is it showing diffusion restriction? No, it's not showing diffusion restriction. So this means it is not restricted. Given these whole findings, which one do you think is? These are the findings. This is the flare, This is the T1 post-contrast, and this is the ADC and the diffusion. Is this A, glioblastoma, B, brain abscess, C, metastasis, or D, tumefactive MS? This is a case of course, A, GBM, glioblastoma. There is nodular enhancement and wall diffusion restriction. See the wall? And this is the clue that I kept or didn't comment on because you have to do something yourself. This is the golden finding. The wall itself is restricted if you compare here. The wall is showing diffusion restriction. So the content is not restricted. The surrounding vasogenic edema, it's not restricted. The wall is showing diffusion restriction. So heterogeneous nodular contrast enhancement, central necrosis, only the wall is restricted, and in cases of butterfly glioma, you'll see it crossing the midline. So congratulations to those who got it. Why not B or abscess? Because abscess usually have thin, smooth ring enhancement, okay? This was thick, nodular, like you said. Why not C, metastasis? Metastasis is usually multifocal. Solitary metastasis can mimic glioblastoma, but ADC restriction or diffusion restriction in the solid part is rare in metastasis. So usually metastasis does not have solid diffusion restriction and usually multiple. This is solitary and have diffusion restriction in the wall. Why not tumefactive MS? Well, because tumefactive MS has incomplete or open ring enhancement. Open ring will cause tumefactive MS. We are off to a great start. Case number 1 down. Before we go to the next case, glioblastoma mimic, GBM can be solitary and can be multifocal. Rarely, but can be multifocal. Sometimes mimicking metastasis. So we need all kinds of clue. This is a unifocal and this is a multifocal GBM. It's rare, but it happens. So in your differential, don't forget multifocal GBM if you got a case like that. And look for all clues. Diffusion in the wall is a very big hint, okay? We will have a flash round, a speed round. We'll do something simple and fast. Flash round, no thoughts, just reflex. Type your answer. What kind of edema is this? This is a vasogenic edema. Hemorrhage is in the gray matter, in the basal ganglia, but the edema, it goes along the white matter tracts to the gray-white matter junction and causes the mass effect and the effacement of the cortical sulci. Good job. Now, second question. What is the name of this CT sign? This is a fatal finding. You have to know it. The patient will die. This is the white cerebellum sign. This is a false or pseudo hyperdensity of the cerebellum when it's compared to the hypodense cerebrum. The cerebrum is the hypodense. The cerebellum is good, okay? Because the rest of the brain is so dark, the cerebellum appears bright, and this is a case of diffuse cytotoxic edema, like everything is edematous. Good job. Flash round is finished. Now, let's go to challenge case number 2, the bleed. Here we have a 70-year-old female patient found unconscious at home. Past medical history, she's on blood thinners, like warfarin. ER diagnosis, probable brain hemorrhage. So, the ER doctor requested a brain CT scan to be done stat, immediately, emergency, and they need an answer very fast. Let's look at that CT scan. Is this a bleed? On CT, an acute bleed that's less than 1 day should be bright white, blood density, hemorrhage density. This isn't white. It's slightly dense. Acute bleed, it should not be like that. So why isn't this patient bleeding brightly? Bleed or no bleed? What do you think? What do we do? What's your next step? Your next clue? What will you think of? It's already white, so contrast white will not be very helpful, but some of you says MRI, and definitely we should do an MRI to have more characteristics. So we will have the important MRI sequences, T2 and flare. And what do we see here? This is a flare and T2. Look at the right parietal lobe. It is dirty. There is an increased signal intensity. There is something here, okay? Compared to the normal left side. This is not just edema. This is a lesion, gray matter and white matter here. If you look carefully, the gray and white matter both are involved. So now, Is this hemorrhage? The final clue. I'll give you one more clue and you have to decide. What will you do next for this patient? Exactly. We need to do a gradient echo, excellent gradient images or susceptibility weighted imaging. Not diffusion, because we are not suspecting an ischemic stroke. We are suspecting bleeding or mass. How to rule out bleeding? You use gradient or susceptibility weighted imaging. And what do we have here? We have these. This is the flare and this is the SWI. There is a marked drop of signal in the lesion. Okay, so there's massive blooming. But why did it look subtle on CT scan? So what's your diagnosis now? Abscess, hyperacute intracerebral hemorrhage, subacute stroke with hemorrhagic transformation, or tumor with associated bleeding. In every case, there is one single piece of information or a clue that I am not emphasizing on, but it is vital for the diagnosis. In this case, the clue is in the history. Remember, what was the history? I told you, past medical history, she is on warfarin. Warfarin will make the blood take more time till clotting. So this case is a case of hyperacute intracerebral hemorrhage, isodense on early CT, because it's hyperacute and it's not clotted yet. Okay, so it's hyperacute, less than maybe few hours, maybe even 1 hour. The patient is on a blood thinner and the blood hasn't clotted, but the susceptibility weighted imaging saved the diagnosis. Why not a stroke with hemorrhagic transformation? Because hemorrhagic transformation happens days later. It does not go to hemorrhagic transformation like in a few hours. Is it diffusion artifact or not? Artifact or diffusion restriction? Fast. Good job, my detectives. This is definitely a T2 shine through artifact because it's hyper intense on diffusion, hyper intense on ADC map. So hyper intense, this is a T2 shine through artifact. Diffusion or artifact? This is a diffusion restriction. It's a real diffusion restriction, real stroke. You can see it's hyper intense on diffusion restriction and it's hypo intense on ADC map. So this is not an artifact, this is a true stroke. Just to compare, this is a shiny through, it's hyper intense while it's a stroke. How to confirm? By ADC. If it's bright on ADC, this is a shiny through. If it is dark, this is a stroke. Good. Now let's take the case challenge number 3, the mass effect. This is a case of a 30-year-old male with motor vehicle accident, unconscious at the scene, severe trauma. So we must check for urgent findings. CT scan was ordered, stat, and CT spine. This is the non-contrast CT. What do you think? Let's look for other slide of the complications. What do we see here? As detectives, we are looking for consequences. We see edema because the ventricles are small. You can see the posterior occipital horns, they are not even seen. This indicates edema, and we can see the cisterns here. This is the fourth ventricle, has small amount of increased density, which indicates blood. Let's go for the final clue. We did a brain MRI for this case. And what do we see here? This is T2 flare showing a mass effect. The ventricles look small, compressed, okay? And this is the SWI. What is this? Severe diffuse cerebral infarction? Is this diffuse axonal injury, B, or C, hypoxic ischemic brain injury, or D, tumor with hemorrhagic component? Diffuse axonal injury. And of course, the key was in the susceptibility weighted imaging. You can see multiple tiny petechial hemorrhages at the gray-white matter junction and surrounding the corpus callosum. Diffuse axonal injury is caused by shearing forces, causing petechial hemorrhages, and it's caused by the rotational and shearing forces of the impact of the trauma. Classically affects the gray-white matter junction, the corpus callosum, and the brain stem, and it will show as petechial hemorrhages on SWI. And this explains why the CT looks relatively not that much. Some brain edema, maybe some ventricles appear small, it's not that much. The patient was glycoma scale of 5. Now, we'll have a summary and a next case teaser. As a summary, glioblastoma mimics abscess, but the core restriction in abscess, while glioblastoma shows wall restriction. This is the teaching point here. Second, fresh bleed, very extremely fresh, may mimic a stroke, but the susceptibility weighted imaging finds it, especially if the patient is on anticoagulation. Third lesson, diffuse axonal injury might mimic some kind of tumor, or might even, you can pass it as normal sometimes in brain CT, but the particular location of blooming on SWI will help you in determining the correct diagnosis. Don't forget to subscribe. And this is your next puzzle. Look at this case: metastasis or glioblastoma. This is the case teaser. This is T2. This is flare, T1. And this is the susceptibility weighted imaging. And this is the diffusion, by the way, sorry. And this is the post-contrast. Question: metastasis or GBM? The clue is in one of the images. One only of the images. Which sequence has the answer, do you think? Which sequence has the clue? The important sequence, or the important image, the one that has the whole diagnosis, is of course the diffusion. And since it's not showing any increased signal intensity on diffusion weighted imaging, we don't need an ADC map. We need an ADC map only if the lesion or the abnormality appears hyperintense on diffusion weighted images. Since there is no increase in the no signs of diffusion restriction, we said that glioblastoma usually show diffusion restriction, while metastasis usually does not show diffusion restriction. So the answer in this case is metastasis, because there is no diffusion restriction, and this metastasis is impinging on the brain and invading the brain parenchyma. So let's start with today's radiology detectives, the deep and dark secrets. So today we are going deeper. We are looking at the basal ganglia and the thalamus. When these deep structure change color or change signal intensity, the patient is often in a race against time. So let's go to work. First, we will have a quick look about the deep anatomy of the basal ganglia. So to be a detective, you must know the neighborhood. Remember, putamen, caudate, globus pallidus, and thalamus. These four parts of the brain that we will look into today. Our clues will depend on which specific part is involved. Is it all the basal ganglia, or just the thalamus, or just the putamen, or just the globus pallidus? Precision is everything. As we know, this blue thing is the lentiform nucleus. It is composed of the medial part, that's called globus pallidus, and the lateral part, that's called the putamen. Anteriorly, in a tail-shaped manner, just like here, it's like a tail, is the caudate nucleus, and you have on the sides of the third ventricle, you have the thalami. So this is the basic anatomy. Now, we have three deep rules. Symmetry is your best friend today. You have structures that are bilateral, symmetrical. So if it is on both sides, it's usually not a stroke. If it is bilateral, symmetrical, it's usually not a stroke. It's likely something the patient ate, inhaled, or missing in their blood. So when it's symmetrical, usually it's metabolic or toxic. Sequence priority here, you need to depend and use the T2 flare for location and diffusion weighted imaging for acute. Is it an acute or not process? And the why, is it blood flow obstruction? Is it poison, or is it nutrition? These are the three deep rules. We have the location, we have the symmetry in our favor, and now we will look into the crimes. We have a suspect lineup. The criminals will be standing next to each other, and we will have to know which criminal committed which crime. One of these is a carbon monoxide poisoning. The other one is vernix encephalopathy. The other one is Creutzfeldt-Jakob disease or prion disease, and the last one is the deep venous thrombosis. So which one of these four crimes is committed by which one of these four criminals? So here are the suspects today. They all attack the deep brain, but they all leave a different fingerprint on the MRI. Let's look at case number 1. The challenge case number 1 is, I call it the kitchen mystery. Winter in Erbil can be cold. This patient was found sleepy, confused in her room. She has tremors. The ER thinks drugs. She's a 20-year-old female patient, found lethargic in her apartment in winter, presented with confusion, headache, Parkinson-like tremors, and the ER, since she's 28 years old, they are thinking of drug use. Okay, so let's start with our first images. We said the main sequence are T2 and flare. So this is the T2 and this is the flare sequence. Look at the glow. Which part is glowing? It's perfectly symmetric. This increased signal intensity, it's perfectly symmetric. It is only in the globus pallidus. The putamen, it's not involved. It's just globus pallidus. The thalamus is not involved. The thalamus is good and normal. Okay? Just the globus pallidus is involved. Does drug overdose do this, or is it something else? So let's go to our second clue. The second clue we said it's first the T2 and the flare, and second it's the diffusion to check for acuity. And this is the diffusion weighted imaging, and this is the ADC map. So the diffusion weighted imaging is bright. The ADC is dark. This is true cytotoxic edema. These cells are dying now. What is the globus pallidus most sensitive to? Is it most sensitive to oxygen, to sugar, or to drugs? So we have bilateral globus pallidus, increased T2 signal intensity, that is showing diffusion restriction. So, and of course, as I gave you in the history, I said winter can be cold in Erbil, and this girl was found alone in her apartment. So when it's winter, we usually use the airspace heater, and this is the winter connection. Radiology is 50% imaging and 50% history. Remember, she was found in closed room in winter. So what gas that loves to eat the globus pallidus because it has the highest oxygen demand, the globus pallidus? The options here are A, methanol, B, carbon monoxide, C, cyanide, and D, lead. So what's the poison? So the reveal in case 1, it's carbon monoxide poisoning. Carbon monoxide poisoning causing symmetrical globus pallidus necrosis. However, methanol affects the putamen. Methanol poisoning affects the putamen. Keep that in mind. To be extra, to have more, let's say, views, we can see the effect of CO poisoning on T2 and the flare, effect of methanol poisoning on T2 and the flare. Here it's affecting the putamen, here it's affecting the globus pallidus here and there, and you can see the diffusion restriction here in the globus pallidus, diffusion restriction here in the putamen. This is due to methanol poisoning, this is due to CO poisoning. We have a flash round, okay? It's called the symmetry test. Flash round symmetry test. So be ready, just answer, don't think. What structure is glowing? 1, globus pallidus. 2, thalamus. 3, putamen. Answer fast. 1, 2, or 3. And of course, the answer is the thalamus. Okay? The answer is the thalamus. Symmetrical thalamic signal. This is our next big mystery. So the diagnostic challenge here, that we will keep it the answer to the end of the case. Is this a stroke? Is this glowing thalami? Is this increased signal intensity, is it your stroke? So we will solve the next problem together. So challenge case number 2, what is wrong? What's the history here? This patient is confused, can't walk. He has classic triad. The triad, it's ataxia, the patient can't walk straight, it's ophthalmoplegia, the eyes cannot move, and it is confusion. So we have ataxia, ophthalmoplegia, and confusion, and this patient was just wandering, 50 years old, wandering in the streets. So clue number 1, the periaqueductal gray matter. Look at the midbrain here. See that bright circle around the aqueduct, this bright thing here, which is here, okay? That is the periaqueductal gray matter. This is a very specific clue. It's like a neon sign for a specific vitamin deficiency, okay? Now, let's look at the image of the flash round session. This is the image. Look at the thalamus. It's not the whole thalamus, it's just the medial part of the thalamus, okay? Near the midline. Plus, if you look carefully, you can see increased signal intensity in the mammillary bodies. They are glowing. These two tiny dots here, the mammillary bodies, they are glowing. This is master signature of this disease. It's one diagnostic disease. So, before we go to the answer, let me give you the final clue. What is this? This is thiamine, okay? The history. He's been wandering in the streets, okay? So this disease happens when the brain runs out of thiamine, which is B1. Without B1, these specific deep structures will fail. What's the name of this emergency? Is it 1, Wilson disease, 2, Wernicke's encephalopathy, 3, Leigh disease, and 4, Japanese encephalitis? The reveal in case number 2, it's of course thiamine deficiency, which is also called Wernicke's encephalopathy. Detectives, remember, medial thalami plus mammillary body equal B1 deficiency. So, Wernicke's encephalopathy with characteristic medial thalamus and periaqueductal gray matter and mammillary body involvement, it's diagnostic of Wernicke's encephalopathy. Excellent work, everyone. One pro tip, look at the mammillary bodies. If you give contrast, they will show post-contrast enhancement. So, if you are in suspicion, give contrast and the mammillary body will enhance if it is thiamine deficiency or Wernicke's encephalopathy, okay? Flash round number 2, it's called the vein game, okay? First question, answer yes or no. Can stroke be on both sides? We have hypodense lesion here and hypodense lesion here. Both thalami, they have hypodense foci. Could this be a stroke? Can a stroke be on both sides? We said symmetry usually is not a stroke, but there is an exception. It is the artery of Percheron. It is a single artery supplying both thalami that can cause bilateral stroke. If one clot came here, the clot will kill both thalami. But there is another suspect that also loves thalami, and it's a vein. Can you guess what other suspect is? It's the deep venous thrombosis of the internal cerebral vein. As you can see here, this is an MRV showing missing internal cerebral vein, and on the flare you can see diffuse signal intensity abnormality of the basal ganglia and both thalami, which is caused by venous sinus thrombosis and venous infarction. So both sides will swell, and always check internal cerebral vein when the thalami are bright. So let's go to challenge case number 3. It's called the rapid decline. This is a 65-year-old quickly fading patient. Final case, 65-year-old patient. He was fine 8 weeks ago. 2 months ago, he's good. And now he does not know his name and his arms are jerking. Alzheimer takes years. This took weeks. This is a rapid mystery, okay? Physical examination show myoclonus or muscle jerks. ER guess Alzheimer. So, as we said, we need first to start with T2, flare, and diffusion. And on the T2 and the flare, we have what's called the hockey stick sign. If you look here, this thalamus has something just like this, okay? I drawn it to you here. It's like the stick of a hockey, okay? The medial aspect, this hockey stick sign, it's classical, it's scary, and it's almost always fatal. Look at the diffusion. You have minimal increased signal intensity on the medial aspect of the thalami showing a hockey stick sign. Now, the clue number 2, it's called cortical ribboning. Look at the surface of the brain. It looks like it's glowing in a thin ribbon. Look, it's glowing in a thin ribbon. Also the same thing, you can see it on the flare. When you see the hockey stick sign in the thalamus and ribbons in the cortex, there is only one criminal, one suspect. So let's start with the interactive vote. Is it 1, Creutzfeldt-Jakob disease, 2. Neurosyphilis, 3. Herpes encephalitis, or 4. Glioblastoma multiforme. Remember, we have rapid dementia, myoclonus, hockey stick sign, and cortical ribbing. Is it a virus, is it a tumor, or is it a prion? Correct answer is, of course, number 1, which is Creutzfeldt-Jakob disease or prion disease. Look for the pulvinar sign, the hockey stick sign, and cortical ribbing on diffusion-weighted imaging. Creutzfeldt-Jakob disease is a prion disease. This is the detective's nightmare because it's so rapid, but the MRI gives the answer when the lab is still not here, or when the lab is still pending. Look at the ribbing and the hockey stick sign. So, in conclusion, globus pallidus involvement, it's carbon monoxide. Putamen involvement is methanol poisoning. Medial thalamus and mammillary bodies, it's vernix encephalopathy. Pulvinar involvement with cortical ribbing, it's Creutzfeldt-Jakob disease or prion disease. Please don't forget to subscribe to the channel if you are not subscribing. Don't forget to share the talks with your friends, with your groups, on your pages. Support me so that we can keep doing these things. Welcome back, detectives. We are conquered the rings and the deep structures. Today, we will enter the forest of white matter. When brain's wiring turns bright, it could be a simple virus or a deadly autoimmune attack. So let's find the clues in today's episode of the Radiology Detectives. It's called the White Matter Files. We have to know what we mean when we say juxtacortical, which means just touching the cortex. This is the cortex here. It's just touching the cortex. This is juxtacortical, and these are called the U fibers because they are shaped like the letter U, okay? And we have the periventricular, which means just around the ventricle, and these parts here are what's called the deep white matter. So these are the three main categories: the juxtacortical or the U fibers, and the periventricular, and the deep white matter. So let me introduce you to the three white matter rules. The three white matter rules. Rule number 1, symmetry. Is it asymmetric or lopsided, or it's mirror image symmetric? This is very important thing when you find an abnormality. Is it asymmetric or symmetric? Second, the U fibers. Are the subcortical U fibers spared or destroyed? And the third rule is look for the enhancement. Does it light up with contrast? The suspect lineup today, our criminals are PML or progressive multifocal leukoencephalopathy, MS or multiple sclerosis, ADEM, which is acute disseminated encephalomyelitis, and D, posterior reversible encephalopathy syndrome, or what we call PRESS. So these are the suspects. Which is which? We have to find the clues. Challenge case number 1. We call it the hiding virus. Case number 1. It's called the 40-year-old weak patient. The history is 40 years old, male patient. He's HIV positive with low CD4 count, or he's an immune suppression. Presentation, progressive weakness in the left arm and cognitive slowing. Our patient is immunocompromised. He's getting weaker over weeks. This isn't just a sudden stroke. It's a slow takeover. So let's look at the MRI. Clue number 1, the asymmetric flare. Look at the pattern. It's messy. It's asymmetric. Look here and here. Look on this side and on the other side. It's messy. It's asymmetric. It involves the subcortical U fibers. It goes right up the edge of the cortex, just to the edge, okay? Does this look like an organized attack or a chaotic one? Let's go to clue number 2, what we call the scalloped edges. The scalloped edges, see that wavy scalloped edge? See that wavy scalloped edge? Okay? That's the virus eating the U fibers. When the virus here, it eats the subcortical U fibers, not the cortex, okay? This is a classic signature. Most white matter diseases spare these fibers, but this suspect loves them. Now the final clue, the absence of contrast. Here, this is the flare or the T2 images, and you can see the subcortical U fibers bright, and on post-contrast images, this does not happen. There is no contrast enhancement, okay? Name the virus. Is it A, HIV encephalitis, B, PML or JC virus, C, herpes simplex, D, CMV? something that attacks the subcortical U fibers, asymmetrical pattern, with scalloping, not involving the cortex, and doesn't show any post-contrast enhancement in an immunocompromised HIV-positive patient. So the reveal of case 1 is PML, or progressive multifocal leukoencephalopathy. It's PML. The JC virus wakes up and destroys the white matter. Remember, if the U fibers are gone, think PML, okay? And look for the scalloped U fibers involvement, and the lack of mass effect and the lack of post-contrast enhancement are very helpful clue for this distinguishing these features. So the HIV encephalitis here, the mirror image, and it stays deep. It's bilateral, it's symmetrical. While the PML on the left side here, it's a chaotic mess that hits the surface, not involving the gray matter. So if it's symmetrical, it's HIV encephalitis. If it is asymmetrical, it's probably PML, or progressive multifocal leukoencephalopathy. Now, flash round number 1, the periventricular check. What are these called? What's the name of these? What are these fingers called? They are Dawson fingers. These are Dawson fingers. This is the hallmark of MS. They follow the small veins perpendicular to the ventricles. There are veins here, and they follow the veins. Okay, question number 2. Is this acute or chronic? Open ring enhancement. Does this mean the MS lesion is active or old? These are acute lesions since there is an open ring enhancement. Now, let's go to the challenge case number 2. Are you ready? This case is called the pressure peak. The pressure peak. Now, this is a 35-year-old seizing patient. This is an emergency, a pregnant patient with extremely high blood pressure and a seizure. The ER says eclampsia, but we need to see the brain. Is the damage permanent? She has severe headache, blurred vision, and then seizure with her blood pressure is 190/110. Now, clue number 1, the posterior predominance. Look at the location. It's almost all in the back, in the posterior parts here. Because the posterior circulation has less sympathetic tone to handle high pressure, it's leaking fluid. The fluid is leaking into the brain parenchyma. Now, let's go to clue number 2. Is this cytotoxic or vasogenic? Come on, guys. We have here, this is the flare image, or the T2, and this is the diffusion, and this is the ADC map. It's not bright on diffusion, it's bright on ADC. So is this cytotoxic or vasogenic? Look at the ADC. It's bright or white. So this is vasogenic edema, not a stroke. This fluid is leaking out of the vessels. The cells are not dying. This means it might be reversible. Now, the final clue, the reversible hint. 1 week later, her blood pressure was controlled, the brain returned to normal. What's the name of this posterior reversible syndrome? Guys, it's easy. Is it reversible cerebral vasoconstriction syndrome? Is it PRES, or posterior reversible encephalopathy syndrome? Is it CADASIL, or the cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy? Or is it MELAS, or mitochondrial encephalomyopathy with lactic acidosis and stroke-like episodes? And the reveal of case 2, this is posterior reversible encephalopathy syndrome, or B. It's PRES. If you catch this early and drop the blood pressure, the brain recovers. This is why it's called reversible. If you miss it, it can turn into a real stroke, and then you'll start having cytotoxic edema. So in the PRES stage, it's vasogenic edema, it's reversible, and if you leave it, it might change into stroke and you get diffusion restriction. Pro tip, be careful, it's not always posterior. Don't let the name posterior reversible encephalopathy syndrome fool you. 25% of the times, PRES can hit the frontal lobes too. Look for the high ADC to prove it's just fluid leaking. High ADC, no diffusion. It can involve frontal or posterior. 25% of the cases are frontal, so be careful. Okay, now, are you ready for flash round number 2? It's called the pediatric puzzle. Fluffy white matter lesion in a 10-year-old after a viral infection. Look at these lesions. They look like MS, but they are fluffy and involve the gray matter too. What do we call this disseminated attack? The answer is ADEM, or acute disseminated encephalomyelitis. This is one and done autoimmune attack. It looks scary, but unlike MS, it usually doesn't come back. Once you have it, you recover, and then it does not come back again. So you have it, or the patient have it, not you. The patient have it, treat, recovers, and he is not at risk of recurrence. Unlike MS. No. Now, question. Is this a white matter disease? Let's go to the next case. I will not give you the answer now. The answer will be revealed in the next case. Challenge case number 3. It's the deep smoker. Now, case number 3, the history is our final case. It's very common. This patient isn't acutely sick. He's just slowing down. His walk is magnetic. The feet stuck to the floor. Is it just aging? He's 55 years old. He's a heavy smoker, high cholesterol, untreated hypertension, with gradually losing memory and having trouble in walking. So, is this just aging? The clue number 1, called the halo of the ventricles. Look at the ventricles. They have a thick white borders here and there, okay? This isn't fingers like MS. It is smooth cap, like a hat, and band. We call this leukoariosis. Now, clue number 2, the silent black holes. Look at these tiny black holes here and here and here, and there are multiple tiny black holes. They are all tiny strokes that the patient never even felt. They are the scars of the long-term high blood pressure. What is the primary cause here? Is it A, small vessel disease, B, Alzheimer, C, neurosyphilis, D, normal pressure hydrocephalus or MPH? Void detectives, smooth periventricular halos, plus lacunes, plus smoking, blood pressure history. What is the diagnosis? A, B, C, or D? In case number 3, it's a chronic small vessel disease. It is the number 1 cause of vascular dementia. The tiny arteries are hardening and starving the white matter for oxygen over years. It is the most common thing you'll all see in any clinic. You'll see these dark holes, you see the capping, you see the brain atrophic changes, and again on the T2 you can see this. This is the Radiology Detective episode 3, and summary and closing. Keep in mind, the white matter files now will be closed. Today we learned that the border or the U fibers and the ADC map are the detective's best tool. PML, look for scalloped U fibers in immunocompromised patient. MS, look for Dawson fingers in the periventricular region. PRESS, look for high ADC or vasogenic edema in the posterior part and in 25% in the anterior part of the brain. Also, small vessel disease, look for smooth halo and lacunes. Don't forget to subscribe, don't forget to share, don't forget to support us by telling your friends. I'm Dr. Ahmed D. Abdulwahab, and the cases will keep coming. Welcome back, detectives. We have navigated the rings, the deep structures, and the white matter. Today, we will face an ancient enemy, infections. When microscopic organisms invade the brain, every hour counts. We must hunt them down before they cause permanent damage. So let's start episode 4. I'm Dr. Ahmed D. Abdulwahab. This is the Radiology Detective. Stay with me. So, first of all, let's start with the infection protocol. Detectives, to hunt these microbes, you must look beyond the scan. Rule number 1, what is the patient history? A virus that attacks an HIV patient looks different than one that attacks a child. Rule number 2, microbes. They have preferred neighborhoods or locations. Learn their neighborhoods and you can solve the case. And rule number 3 is enhancement and edema. How angry is the brain reaction? How does it react to the invasion, to the invader? Okay, so these 3 rules are very, very important. Rule number 1, patient immune status. Is the door to the brain open or closed? Location, where does the microbe prefer to live? Is it in the temporal lobe, the basal ganglia, and the meninges? And rule number 3 is the enhancement and edema. How angry is the brain reaction? Now, the 3 infection signals that we must see in every case. These are the diffusion-weighted imaging and ADC, which tell us that the infection is acute if it is restricted. That's true infection or pus. Second is the T2 and flare, tell us the swelling and the angry tissue, and the post-contrast T1, identifying the wall or the ring or the surface, the meninges. Diffusion-weighted imaging is the primary weapon. True infection often restrict diffusion because of pus. Post-contrast T1 is your secondary weapon. It shows us how the body is fighting back the enhancement. We have used these before. Today, we master them in infections. Now, let's get ready for the suspect lineup. We have 5 suspects today, and these are, there are your 5 targets today, a diverse lineup of viruses, bacteria, and parasites. Each one requires a different strategy. Let's find out the first victim. The suspects are herpes simplex virus, pyogenic or bacterial abscess, neurocysticercosis, a parasite, tuberculosis, and toxoplasmosis. So let's start with our first crime or first suspect. Challenge case number 1. I call it the temporal trap. The 15-year-old with fever and confusion. A healthy teenager suddenly becomes confused and aggressive. He has a fever. The ER thinks drugs or psychosis. We must look closer. This is a classic presentation that often hides a deadly secret. Again, this is a 15-year-old male patient presented with 2 days of sudden onset of fever, headache, and severe confusion and behavioral changes. Initial ER guess is drug use, abuse, or psychosis. So let's look for the clue number 1, the T2 and the flare, the temporal globe. Look at the screen. The left temporal lobe is angry. It's bright on flare, but look closely. It is not a round ball. It follows the shape of the temporal lobe. It is a gyriform and involves the cortex. You see here, the cortex is involved with the gyri. Okay, what specific common virus loves this neighborhood? Think the cold sores. Okay, let's go to clue number 2, the insula and the asymmetry. Detectives, look at the insula, the hidden lobe. This is the hidden lobe. It's glowing too. This pattern of temporal lobe and insula and cortical involvement is highly suggestive of one specific type of viral encephalitis. Let's go to clue number 3, the hemorrhagic transformation. We did susceptibility weighted imaging. See those black dots? That is microhemorrhages. These black dots, this is microhemorrhage. This virus doesn't just inflame, it can cause bleeding. The neighborhood, the cortical involvement, and the bleed, you have all the clues now. Is it A, CMV or cytomegalovirus, B, herpes simplex 1 virus, C, Epstein-Barr virus, and D, varicella-zoster virus? If you treat this with a cyclovir immediately, you can save this boy. What is it? The reveal of the case 1, herpes simplex 1, the answer is B. The virus that gives you cold sores can travel up to the nerves and devastate the temporal lobes. This is a clinical emergency. If you see this pattern, call the ER immediately. Herpes simplex 1 is in the temporal trap. Peer number 1, cause of sporadic fatal viral encephalitis. It's fatal. Classically, it presents as asymmetric mesial, temporal, insular, and inferior frontal lobe involvement. Cortical swelling and petechial hemorrhages are common. Temporal lobe, okay, insula, and microbleeds. One of the very confusing things that can mimic herpes simplex virus encephalitis is paraneoplastic encephalitis. Paraneoplastic or autoimmune encephalitis, this thing here, can also hit the temporal lobe. You see the temporal lobe here is swollen, okay, and here the difference, it's often perfectly symmetric and bilateral. You can see here the temporal lobe is perfectly symmetrical bilateral involvement in paraneoplastic encephalitis, while herpes simplex is virus encephalitis, usually messy, asymmetric. Okay, messy and asymmetric. So symmetry is again the best clue for you. Flash round number 2. It's called location check. Question 1. What structure is infected? Hint, this is the second favorite neighborhood of herpes simplex encephalitis. Answer to question number 1 is the frontal lobe, specifically the inferior part of the frontal lobe, and the herpes simplex here can travel via the olfactory tract, okay? And always check the inferior frontal lobe for infection. Question 2, is this gray or white matter infection? Let's go to challenge case 2. It's called the ring redux. A gradual headache and fever after a dental procedure. Is it a tension headache or did a bacteria make it past the firewall? This is a 50-year-old male with recent severe dental work with root canal complications, presented with headache and low-grade fever that have gradually increased over 1 week. Clue number 1, the non-contrasted scan, the flare, and the T2. Look here. Here we go. Ring lesion number 2. In episode 1, we learned that GBM has thick walls and metastasis is usually multiple. Look at this ring. It has a bright center and a huge vasogenic edema. Bright center with a huge vasogenic edema. What's the next scan or sequence you want to see? And this is detectives. This is your primary diagnostic weapon against bacterial infection. Look at the ADC. The entire core of the lesion is black. Okay? Low ADC, this means intense restriction. Okay? True pulse, restrictive in nature. Is this a GBM or is it an abscess? The center is restricted here. So let's go to the final clue. The ring wall on flare and T2. Let's re-examine the flare and T2. Notice how smooth and thin that ring is. Look, the ring is very smooth. Okay? It has a subtle dark edge. Very subtle. The edge is a little bit dark. Okay? This smoothness is the signature of a benign, smooth capsule, not the rough, thick wall of GBM. The clues are all there. Name the ring. Is it A, GBM, B, tumefactive MS, C, brain abscess, pyogenic, and D, metastasis? Thin, smooth ring plus intense ADC restriction, which equals pus or tumor. The reveal of case number 2 is pyogenic or bacterial infection. Abscess, bacterial pus. Detectives, this case was the opposite of case number 1 in episode 1, which was a GBM. In a GBM, the wall might restrict, but the center is necrotic and have high ADC. In an abscess, the center is pus, which is intense restriction. ADC makes the diagnosis. This is our case from episode number 1. You can see the center is not restricted. So, thin, smooth ring with intense central diffusion restriction. This is pus. Smooth capsule show as dark on T2 or flare. The rim is dark. GBM has thick irregular wall that does not show true central restriction, just T2 shiny through or necrosis. Got it? Pro tip for you guys, abscess versus tumefactive MS. Tumefactive MS can also restrict. The key difference, abscesses usually make a complete ring while MS makes an incomplete ring. This is the MS showing an incomplete ring while abscess show a complete ring. The small difference change the diagnosis from bacteria to autoimmune. The devil is in the details. So keep in mind, abscess show thin smooth ring with intense central diffusion restriction. The smooth capsule often appear as dark on T2 and the flare, while GBM show thick irregular wall that does not show true central restriction, just T2 shiny through and necrosis. Are you ready for flash round number 2? It's called sequence showdown. Question, is this pyogenic pus? No time. Can you tell this is abscess only with this post-contrast T1 image? So of course the answer is no. This is not an abscess. Contrast only shows the wall. You must have ADC and diffusion to prove the center is pus. Contrast without diffusion is just a broken wall. Diffusion tells you what is inside. What is this sequence? Look at the ventricles. They are black and dark. So of course this is flare. So let's go to challenge case number 3, the multiple dots. What do we have here? Seizures, new onset in a 30-year-old. He has no prior history. This is not developmental. Something acquired is causing this, and since he just moved, we must think globally. He just moved from outside. This is a 30-year-old male with history. He's from native or of Central America, recently moved, presented with a new onset generalized seizure, no history of epilepsy. Clue number 1, the dots. Okay, look at this. It's like a shotgun blast of lesions everywhere. Lesion here, lesion, everywhere lesions. These are multiple dots. Some are bright cysts, some are dark, but look closely at one of the cysts. Look here. See that tiny black dot just in the center? Black dot here? That's this calyx, the parasite's head. This is a defining clue. Let's go to clue number 2. Enhancement. Notice that some of these lesions light up while others are quiet. Some of them show enhancement. For example, this one shows enhancement. This one does not show enhancement. Again, this one, minimal enhancement. So there are variable degrees of enhancement. They are in different stages of life. When you see multifocal cystic lesions at different stages, you are hunting a parasite. Now, that's all your clues. What is the diagnosis? Is it A, metastatic disease, B, toxoplasmosis, C, neurocysticercosis, and D, diffuse axonal injury? Multifocal cysts plus colices, dot in the cyst plus different enhancement stages. Which suspect did this shotgun blast of lesions? Is it A, B, C, or D? The answer is C, neurocysticercosis. Parasitic infection by the pork tapeworm. Detectives, this shotgun blast of multifocal lesions is a classic pattern. Why not metastasis? Metastasis rarely has a scolex or dot inside and usually has much more edema. This pattern is just too distinct. So keep in mind, shotgun blast, appearance of multiple cysts at the gray-white matter junction, just like here, and the dot in the cyst or this scolex or the head of the parasite, it's a defining sign. Lesions are often seen at multiple stages, can be vesicular stage or cyst, colloidal stage, which is the angry or the enhancing stage, and finally calcified, which represents the dark or the dead dots. Now, let's get ready for flash round number 3. It's called Spot the Scolex. Question, can you find the scolex? Post-contrast T1 axial image. Yes, we can find the scolex in this magnified view. You can see the cyst and the tiny enhancing scolex here. Again, here the cyst and the tiny enhancing scolex, and so on. Question 2, and this little bit confusing. Is this a neurocysticercosis? This is a new onset seizure in a trauma patient. Is it a neurocysticercosis? What's the sequence? It's the susceptibility weighted imaging or hemo or gradient recalled imaging. So these tiny dots represent tiny bleeds at the gray-white matter junction. When I'm telling you this is after trauma, representing diffuse axonal injury. Now, let's go to challenge case 4. It's called the basal mystery. Now, detectives, remember rule number 1. The status or the history. This patient has an HIV. His CD4 count is low. The door to his brain is open to opportunistic infections. ER says meningitis. Let's look, before we look at the imaging clues, the history is 6-year-old, unwell, male. He has HIV, not on antiretroviral therapy, with low CD4 count and chronic cough, presented with a progressive headache, neck stiffness, and fever. Clue number 1. Basal cistern enhancement. Look at the base of the brain, the cisterns, which should be dark and empty. They are full of thick, bright enhancement. See here, they should be like that. This is the normal, dark and empty. Now they are full of bright enhancement. We call this basal meningitis, which classic opportunistic infection love to fill the basal cisterns with thick inflammation. Let's go to clue number 2. See all the clues, then diagnose. Clue number 2, associated hydrocephalus. You can see here, there is hydrocephalus also, and there is increased transepidermal flow. You can see here. Look at the consequences. The ventricles have expanded. The basal inflammation is blocking the CSF. This rapidly developing hydrocephalus is a major complication of basal meningitis. This patient needs urgent CSF diversion. What did this? Is it A, meningococcal meningitis or acute bacterial meningitis? Is it B, toxoplasmosis, C, tuberculosis, or D, Cryptococcus neoformis? Low CD4 plus thick basal cisternal enhancement plus progressive hydrocephalus. The case for number 4, it's C, or tuberculosis or tuberculous meningitis. In an HIV patient, TB is often the first opportunistic target. The basal cisterns predominantly is high. Why not Cryptococcus or D? Cryptococcus can look identical, so we need a CSF culture. But on imaging, your clue is thick basal cisternal disease. This is a case of bacterial meningitis. You see, it's usually thick. So, TB and Cryptococcus love to settle in the basal cisterns, causing thick, angry exudate that blocks the CSF. So you need CSF culture to differentiate, okay? Cryptococcus and TB. Urgent complications. Acute meningitis usually cause more diffuse surface enhancement, like this. This pattern of enhancement is bacterial meningitis, while this is a cryptococcal meningitis. Just like TB, it's in the basal cistern and it's thick basal meningitis. This is the TB meningitis, this is the cryptococcal, and this is the bacterial meningitis. Now, let's go to the final case, the challenge case number 5. It's called the basal ganglia foci. Here, the last case, rule number 1 again, a very low CD4 count. He has stroke-like symptoms, but he's 35. Stroke in an HIV is usually not ischemic. It's often infectious. This is an infection masquerading as a stroke mimic. The history is that 35-year-old male with a newly diagnosed HIV infection and CD4 count of less than 100. Presentation, sudden left-sided weakness, stroke-like, and seizures. Clue number 1. Let's go and do an acuity check. We'll see if it's acute or not. Go for diffusion-weighted imaging. We always start with diffusion-weighted imaging. What's the rule number 1 of episode 2? Check the other side. ADC is not dark. Dark on the diffusion and it's hyperintense on ADC. It's intermediate density. This means that it's not pus. If the center of the lesion does not restrict intensely like pus, it's something else. We are not dealing with a pyogenic bacteria. What are we dealing with? Look here. It's not restricted, not like the pus, not like the abscess. Again here. Let's go to clue number 2. It's called the thalamus and the basal ganglia neighborhood. Look at the neighborhood. The thalamus, the basal ganglia, when you are an HIV patient with a low CD4 count and multiple non-restricting lesions in the basal ganglia and the thalamus, your suspect lineup narrows dramatically. Look at the neighborhood, the thalamus and the basal ganglia here and here, okay? And this is the post-contrast images. You can see the enhancement. So is it brain abscess, pyogenic? Is it toxoplasmosis, B? Is it C, tuberculosis, CNS tuberculomas, D, primary CNS lymphoma? Patient of HIV plus CD4 of less than 100 plus non-restricting thalamic lesions. This is a clinical emergency, often treated with empiric antiparasitic therapy. The answer is B, or toxoplasmosis. It's another parasite. This is the classic signature, multiple deep structures, thalamic and basal ganglia lesions that don't restrict. If the ADC isn't black, don't think abscess. You all did a phenomenal job. Again, let's look here. If the ADC is not restricted, it's not abscesses, and again, you can see here, it's edematous, but showing some enhancement and no restriction. It's bright on diffusion on ADC map. So in conclusion, remember, herpes simplex virus, it involves temporal lobe swelling and asymmetry, while abscess, there is an intense diffusion restriction because of pus. Neurocysticercosis, dot in the cyst sign, and a shotgun blast. It's multiple, a lot. TB and cryptococcosis, thick basal cisternal enhancement, and toxoplasmosis involves the basal ganglia and the deep structures and show non-restricting lesions. Episode 4 proved that rule number 1, patient history, is as important as rule number 2, which is the location. We use diffusion-weighted imaging and ADC and contrast as our weapons. Keep your eyes sharp and your mind sharper. Subscribe to the channel and tell your friends about us. Hit the subscribe button and share these episodes with your friends. Today, we are not hunting cells. We are deciphering signals, specifically the deep thalamic and basal ganglia signals. When these structures turn white symmetrically, the brain is usually suffering a quiet, deep metabolic or ischemic crisis. We must decode the silent signal before it's too late. So let's start. First, we will have some anatomic refresher, the big 3 from the last few episodes. And as we all remember, we have the thalamus, the lentiform nucleus, and the caudate nucleus. These are the big 3. The lentiform nucleus is composed from globus pallidus and putamen. This is the caudate nucleus, the head and the body and the tail. So to survive today, we must recall the neighborhoods: medial versus lateral thalamus, the putamen, which is the outer part of the lentiform nucleus, versus globus pallidus, which is the inner part of the lentiform nucleus. Each pathology has a different anatomical preference. Today, we must be precise. Now, the symmetrical signal protocol is 3 points. First, symmetry. Is it perfect mirror image? If it is perfect mirror image, usually means metabolic or toxic. Second, acuity. What does the ADC say? And enhancement. Are the deep veins involved or not? So detectives, to decode the signal, follow this protocol. Rule number 1, if it is symmetrical, it's almost always toxic or metabolic. An artery does not clot perfectly on both sides at once. Rule number 2, acuity. Use the ADC to separate old from new. Rule number 3, when the deep structures swell, always check the deep veins. A deep venous thrombosis looks different than carbon monoxide poisoning. Now, the suspect lineup for episode 5. Focus, we have 5 bad suspects. We have venomous insult like scorpion or snake bite, lice disease, Wilson disease, hemolytic uremic syndrome, and methanol poisoning. So here are today's 5 advanced suspects: venoms, genetic diseases, and rare toxins. This is a very complex lineup. You must use all your deductive skills to crack case number 1. Are you ready for case number 1? I call it the kitchen mystery 2.0. If you remember, we had the kitchen mystery in the previous episodes. So this is the kitchen mystery 2.0. And the case number 1 is, this is a 45-year-old partygoer. He was found comatose after a house party the night before. Initial presentation, unconscious, Glasgow Coma scale of 4, acidotic. Initial ER guess, drug overdose. Again, this guy was found unresponsive after a party, acidotic. The ER is treating for standard overdose, but the patient is not responding. We are called in for a comatose neuroscan. Let's look at the clues. Clue number 1, symmetrical glow. Here is the glow, perfectly symmetrical. What neighborhood is it in? The putamen, the outer basal ganglia structure. This is different from CO poisoning, if you remember, from episode 2, which targets the inner pallidus. We are dealing with an outer basal ganglia pathology. So, globus pallidus, putamen. Again, putamen, globus pallidus. So, the putamen is glowing. So, the first question, acid or drugs? So, let's see clue number 2. It's called the colostrum sign. Detectives, look at the colostrum, that tiny outer ribbon, here and here. This tiny outer ribbon, it's glowing too. This specific signature of putamen plus symmetrical colostrum involvement points to a specific toxic metabolic alcohol often consumed by mistake at some parties. Now let's see the final clue, the hemorrhagic necrosis. Susceptibility weighted imaging is our final clue. Look at the bleed here and there. This toxin causes deep hemorrhagic necrosis, symmetrical, putamen, swelling, bleeding. You have the clues. What party toxins causes a putaminal hemorrhagic necrosis? What's the toxin? Is it A, carbon monoxide poisoning, B, methanol, C, cyanide, and D, ethylene glycol? If you miss this, the patient can become permanently blind. What is the diagnosis? The reveal for case number 1 is B, or methanol poisoning. So, classic signature of symmetrical putaminal hemorrhagic necrosis, and it's often consumed in what's called bootleg alcohol, which means cheap alcohol. The non-toxic alcohol is called ethanol. Methanol is bad. So, mimic check. Suspect number 8, CO poisoning. It targets the globus pallidus, not the putamen, and it rarely bleeds this intensely. Cyanide, which is suspect number C, or letter C, it is similar to methanol, but less associated with hemorrhage. Acidosis is key clinical finding. So, methanol found in windshield washer fluid or fake alcohol, it turns into formic acid, which is toxic to the putamen. Remember, globus pallidus is CO, putamen, methanol. You've saved this patient. Before we go, let's compare the CO poisoning versus methanol poisoning. This is the CO poisoning. Look at the visual distinction. Anatomy is your strongest clue. CO hits the globus pallidus, while methanol hits the putamen. Never forget the neighborhood rule. Again, you can see here, this is the methanol and this is the CO poisoning. Are you ready for flash round number 1? It's the acuity check. Question, acute or chronic? This is the diffusion weighted imaging and this is the ADC map. Acute or chronic? The ADC, it's not black. Is this an acute event or with restricted diffusion? And of course, the correct answer is no. It is not acute. It's a chronic because this is hyperintense and this is hyperintense. So it is an artifact, which is a T2 shiny through artifact. So it should be black on ADC if it is truly acute cytotoxic edema. If the ADC is intermediate or bright, it means it's an all damage or just shiny through artifact. We are looking for an acute signature, and this is not acute. Now, question number 2. On diffusion weighted imaging, no ADC map. Acute or chronic based only on this bright diffusion weighted image. So let's go to challenge case number 2, called the red flag pediatric signal. Now, challenge case number 2, the 2-year-old slowing down. A child who was hitting her milestones and now she is unlearning them. This is a progressive neurodegenerative genetic emergency. Pediatric detectives, we must look at the deepest structure. Before we go to the first clue, remember, it's a 2-year-old female presented with a gradual loss of milestones, used to walk and talk, now cannot. Clinically, she has failure to thrive, hypotonia, and progressive neurological decline. So, clue number 1, it's the midbrain and periaqueductal gray matter. Look at the midbrain, perfectly symmetrical. Periaqueductal gray matter and substantia nigra are glowing. In episode 3, we said periaqueductal gray could mean vernix encephalopathy or B1 deficiency, but a 2-year-old child, this midbrain signal has a much more dangerous meaning, genetic or vitamin. So let's go to clue number 2. It's called the deep nuclei. Now, it is not just the midbrain. The deep nuclei are involved symmetrically. This is a diffuse deep brain crisis. If you see this in a child with failure to thrive, you are dealing with a mitochondrial disease. You can see the deep gray matter, the basal ganglia nuclei. They are hyper intense on diffusion weighted imaging, and they are hypo intense on ADC map. So if you see this, it's a diffuse brain crisis. If you see it in a child with failure to thrive, we are dealing with a mitochondrial disease. Now, let's go to the final clue, the mitochondrial failure. We did an MR spectroscopy. See that giant upside down peak? This one? It's a lactate peak. This means the brain mitochondrial batteries have failed. Symmetrical deep nuclei plus lactate peak. This pediatric emergency has a famous name. Name the pediatric emergency. Is it Leigh disease, vernix encephalopathy? Is it hemolytic uremic syndrome or Wilson disease? In a child, the periaqueductal gray matter is almost always this suspect. What's your diagnosis? It is Leigh disease. This child mitochondria cannot produce energy, leading to deep brain failure. In episode 3, the periaqueductal gray matter meant vernix encephalopathy, but in a baby, it's almost always means Leigh disease. Anatomy and age are the definitive clues. Keep in mind, subacute necrotizing encephalomyelopathy, it's mitochondrial. Look for symmetrical T2 or flare signal in the midbrain, in the periaqueductal gray matter, the subthalamic nuclei, basal ganglia, the putamen. MR spectroscopy, you see the lactate peak, which is crucial, and it is a very important clue. Let's compare vernix with Leigh disease. Look at the screen. Vernix, which is on the right side, this one here, loves the medial thalami and the mammillary bodies. Here, the mammillary bodies are important landmark, and the medial thalami. Plus, it shows post-contrast enhancement, while Leigh disease loves the midbrain and the deep basal ganglia, okay, with no enhancement. One of them is B1 deficiency, the other one is a lethal genetic flaw. So differentiate carefully, it's important. Let's go to flash round number 2. It's called target check. So, first question, what target is glowing? Is it the thalamus, the basal ganglia, or the midbrain? Which part of the basal ganglia? Is it putamen globus pallidus? Well, of course, here it's the putamen and the thalamus. It's not the globus pallidus. The medial part, the globus pallidus, looks good. The putamen is hyperintense, and the thalamus, the medial part of the thalamus to be specific. So putamen and medial thalamus are involved. This is the target sign of a famous deposition disease. Think about it. Now question, is this a stroke? Is it a single arterial stroke? Remember the symmetry rule. Is it a single artery stroke? It's not a stroke. It is a famous deposition disease. We will talk about it later. Let's start with challenge case number 3. It's called the deep venom. Now, this is a child recovering from a bloody diarrhea and cannot make urine. Then she has a seizure that won't stop. We must find the link between the blood and the urine and the brain. So, again, it's a 10-year-old female child with recently recovered from a severe stomach flu with bloody diarrhea and oliguria, not making any urine. Presentation, 1 day of sudden status epilepticus, seizures that won't stop. Let's look at the signal. First of all, symmetrical thalamic and basal ganglia glow. Here is the glow again. Symmetrical basal ganglia and thalamus. Why? Why would a child have a symmetrical deep structure swelling after bloody diarrhea? What is this venom or toxin causing? Look at the basal ganglia, it's glowing, okay? Look at the thalamus, again, maybe not that much, but again, it's hyper intense. So what's your theories? Let's go to clue number 2, the acuity check. Now let's see diffusion weighted imaging. Diffusion weighted imaging here is bright. okay? And ADC, it's black. So this is true cytotoxic edema. This is acute dying tissue. Something has clotted the smallest vessels in the deep brain. Bloody diarrhea plus oliguria plus true deep brain restricted diffusion. This has a famous, dangerous name. Let's go to the final clue. For the first time, we will have a blood film. It's called the blood connection. We did a blood count. Her red blood cells are fragmented, like here, like here, like here, like here. Schistiocytes, we call them. Her platelets are low. She has thrombocytopenia. The bloody diarrhea was caused by E. coli, what's called Shiga toxin. That toxin has reached the brain and clotted the deep vessels. You have all the clues now. What clotted the brain? Is it A. Ley disease, B. Wernicke's encephalopathy, C. hemolytic uremic syndrome, or D. Wilson disease? This is a critical triple threat. What is the diagnosis? And the reveal is, of course, case 3 is hemolytic uremic syndrome. The Shiga toxin destroys the lining of the smallest vessels, the microvasculature I'm talking about, in the kidneys and the brain, causing massive clotting and deep cytotoxic edema. Bloody diarrhea is the key. You have solved case number 3. So keep in mind, classic pediatric triple threat is microangiopathic hemolytic anemia, thrombocytopenia, and acute renal failure. CNS involvement by status epilepticus is common, and MRI will show symmetric cytotoxic edema in the basal ganglia and the thalamus. Shiga toxins destroys the deep microvasculature. Now, let's compare Wilson disease with the hemolytic uremic syndrome. Detectives, look at the mimic, the Wilson disease here, the one we saw in the flash round. Wilson disease hits the putamen and the thalamus symmetrically, just like hemolytic uremic syndrome. But Wilson disease is chronic copper deposition. In hemolytic uremic syndrome, the blood diarrhea is there and the ADC is black, meaning true restriction, true diffusion restriction. This tells you this is an acute Shiga toxin. This is acute Shiga toxin, while in Wilson disease, it's chronic copper deposition. So, history and acuity are the key differentiators. Let's go to flash round number 3. It's called the sequence and the toxin. Now, question number 1. What toxin caused this hemorrhage? We did this in episode 2. Look at the inner structure, the globus pallidus here, and look at the susceptibility weighted imaging, the globus pallidus showing hemorrhage. Perfectly symmetric. Clue, what gas caused this kitchen mystery 1? This is, of course, for everyone who attended all the episodes, this is carbon monoxide poisoning. Symmetrical pallidal hemorrhage is CO until proven otherwise. Never, never, ever forget this fingerprint. Question number 2. Is this putamen or pallidus? Let's go to challenge case number 4. This is the comatose. This is a sudden coma in a 70-year-old patient during day. The ER thinks stroke. We are called in for an urgent deep scan. But this comatose presentation is much deeper than a standard arterial clot. Before we look at the first clue, let's review the history. It's a 70-year-old male patient presented with sudden onset of Glasgow Coma scale of 6, which is unconscious during the day, presented as a comatose patient with right-sided hemiplegia, and he cannot move. And initially our guess is stroke. Let's go to the first clue, the symmetrical thalamic glow. Detectives, look at the glow. Perfect symmetric. It's only in the thalami, okay? Symmetrical thalamic swelling. If it is symmetrical, what did I tell you? It's usually toxic or metabolic. That's rule number 1. Is this CO poisoning? Is it Wernicke's encephalopathy? Let's go to clue number 2, the acuity check, diffusion and ADC map. On diffusion, it shows some increased signal intensity. It's a little bit bright. And on ADC, it's black. This is true cytotoxic edema, acutely dying thalamic tissue. But it's perfectly symmetric. Look here. Does Wernicke's look like this? Does an artery of Percheron look like this? Remember, the artery of Percheron is an exception. There is a diffusion restriction, both thalami perfectly symmetric. And just the thalami. So let's go to the final clue. It's called the vessel of origin. Now, this is the final clue. Detectives, we re-examined the T2. See those bright internal cerebral veins? These veins, they should be flow void. They are swollen and clotted. They should be dark, T2 signal void. So we did an MRV. and the entire central deep venous system is missing. Bilateral thalamic involvement plus cytotoxic edema plus swollen bright T2 veins plus not visualization on MRV. This is not an arterial problem. It's not metabolic. What clotted the deep brain? Is it A, artery of Percheron infarct, B, Leigh disease, C, deep venous sinus thrombosis, and D, CO poisoning? So the reveal is, of course, for case number 4, it's the deep venous sinus thrombosis, including internal cerebral vein. The deep venous thrombosis, if the veins cannot drain the thalami will swell and die symmetrically. Detectives, this is perfectly symmetrical pattern, and this is the exception of rule number 1. We said symmetry equals metabolic, but this is an exception. It is a single clot, deep venous thrombosis, and it looks symmetrical because one system drains both thalami. Always check the internal cerebral vein. Look, it's symmetrical, it's showing diffusion restriction, and the MRV is abnormal. Let's compare the artery of Percheron with venous thrombosis. Look at the final mimic here. The deep venous thrombosis left is pure thalamic, okay? While the Percheron here on the right, it's almost always hits the midbrain and the medial aspect of the thalamus. It's called the V sign, okay? And usually has a normal vein signal on T2 weighted imaging. So check the veins, find the midbrain, and then you will find the truth. Now, in conclusion, CO poisoning, it's symmetrical pallidal hemorrhage. Methanol poisoning, symmetrical putaminal hemorrhage. Venous thrombosis, symmetrical thalamic cytotoxic edema. Check internal cerebral veins. And artery of Percheron, symmetrical thalamic cytotoxic edema. Check the midbrain V sign. Again, deep thalamic signal mastered, we use symmetry, acuity, and neighborhood. Methanol, putamin, CO, pallidus, venous thrombosis, thalamus, T2, see the veins, versus artery of Percheron, midbrain V sign. You can crack these cases, you save a life. Genetic and pediatric, let's keep in mind, Leigh disease involves symmetric pediatric midbrain plus subthalamic glow. ADC, it's variable, but there is a lactate peak. Vernix encephalopathy involves the medial thalamus, the mammillary bodies with post-contrast enhancement, while hemolytic uremic syndrome, symmetrical pediatric thalamus, and basal ganglia glow, ADC, and diffusion-weighted imaging, black restriction plus bloody diarrhea in the history. Finally, the pediatric deep signals in the baby's periaqueductal gray matter is Leigh disease. In adults, it's Vernix, B1 deficiency as in episode 3. If a child has bloody diarrhea and symmetric thalamic restriction diffusion, it's hemolytic uremic syndrome. Thank you for joining the Radiology Detective series. Share this content with your colleagues. The detection process never stops. Keep practicing visual patterns recognition. So, to sharpen your eyes for the next challenge, make sure to subscribe and hit the bell so that any episode that comes online, you are there to watch. And the next case file is already open. And don't forget to smile. So today we will start with our presentation. Today is the 6th episode of the Radiology Detective, and again it's about neuroimaging. And today we will talk about the spine files. First of all, to solve the spine mystery, you need a system. I call it the ASM protocol. A is for alignment, S is for signal, and M is for marrow. Check the spine lines. Are they all straight or as they supposed to be or not? Is there spondylolisthesis? Is there trauma? And it all starts with the curves. Second, verify the cord intensity. Is the spinal cord of normal signal intensity or it's bright or white on T2 weighted imaging? Check for if there is any myelomalacia or myelitis and look at the marrow signal. Dark T1 signal of the marrow, it's the red flag that you should be very worried about. It can be metastasis, sometimes can be just aging. Look at the pedicles. Okay, so the suspect lineup for today, we have these 5 suspects. Here's our heavy-hitting lineup, and let's open the first case. The first case is called the heavy lifter. So, the heavy lifter. This is a 35-year-old male patient. He was lifting a heavy box at work and felt a pop. Now, he has lightning pain shooting down his right leg to his pinky toe. He can't stand on his tiptoes. Detectives, this is a classic S1 radiculopathy. Again, this is a young male patient who was doing some lifting, and he felt a pop with severe low back pain, radiculopathy, numbness in the lateral foot, and weakness in the plantar flexion. So let's check the L5S1 junction. Is it a bulge? The L4-5 junction, I'm sorry. Is it a bulge or a disc fragment? And as we said in the lumbar spine, in the spine rule, look at this L4-5 level. There is a huge chunk of disc pushing back, but look at the shape. The base of the disc space is narrower than the piece in the canal. The base is narrower than the piece in the canal. We have a specific word of this. So is it a protrusion or extrusion? So this is an extrusion. Your answer is correct. So now, is the disc material moving up or down away from the disc? Look at the sagittal view. The disc material isn't just sitting there. It has moved behind the S1 vertebral body. When it migrates, now detective knows that it's not just a simple disc bulge. It's something else. So is it migrating up or down? The disc fragment is migrating downward. And now, is it A, epidural abscess, B, transverse myelitis, C, spinal metastasis, D, disc extrusion, or E, cervical myelopathy? Of course, the answer is disc extrusion, but this is wrong. At L4-5 level, the answer is disc extrusion. Keep in mind, a protrusion has a wide base, while extrusion has a narrow base or narrow neck. This is an extrusion with inferior migration, okay? This is an extrusion with inferior migration. Now, are you ready for the flash round? We have flash round number 1. It's called the exit. In the lumbar spine, does the L4 nerve root exit above or below the L4-5 disc? As you can see here, this is the L4-5 disc, and this is the L4 nerve root exiting above the disc. L5 is the traversing root. Again, you can see here, this is the L4-5 disc, and the L4 is exiting above it. If a disc herniates far lateral into the foramen at L4-5, which root does it hit? The far lateral disc will hit the nerve root that is already exited. Okay, like at L4-5, it will hit the L4 because we said L4 will exit above the L4-5 disc. So the nerve root that's already exited, which is the L4, will be involved in a far lateral disc protrusion. Where does the traversing root get squeezed usually? Will it get squeezed in the spinal canal, at the exit foramen, at the recess, or elsewhere? So if this is a disc and the nerve root is exiting, where exactly do you think it will be squeezed? Most accurate site for the exiting or the traversing, the key answer here is the traversing root. The traversing root gets squeezed at the recess. So the subarticular recess is where the root gets squeezed. So it's mainly in the recess. Now, let's go to challenge case number 2. This is called the angry cord. This case is a 25-year-old female with no history of trauma. She woke up and couldn't feel her legs. By midday, she was paralyzed from the waist down. She had a flu-like illness 2 weeks ago. This is a rapid and devastating neurological decline. Again, a 25-year-old female, sudden paralysis, rapid onset over 24 hours with sensory level at the level of the umbilicus. She has bilateral symptoms, no history of trauma, with a viral infection 2 weeks ago. Now, let's go to the clue number 1. The first clue, it's the long sagittal signal. Look at the thoracic cord. It's glowing white. It's white, but count the segments. There's 1, 2, 3, 4, 5, and 6, and probably even 7 segments. This is an emergency. These are all the clues you'll have. The history and the sagittal T2. Is this an epidural abscess, cervical myelopathy, spinal metastasis, disc extrusion, or transverse myelitis? This is acute transverse myelitis. In the spine files, we call this LETM, which stands for longitudinal extensive transverse myelitis. LETM, longitudinal extensive transverse myelitis. We must rule out neuromyelitis optica in this case, also myelin, oligodendrocyte, glycoprotein antibody-associated disease, or what's called MUGAD. This patient needs IV steroids immediately. If the signal is more than 3 segment long, think LETM, okay? Key clue, more than 3 vertebral segments, occupies more than 50% of the spinal cord cross section. Let's go to flash round number 2. It's called sequences, the physics reflex. Sequence showdown. Detectives, look at the screen. Which sequence is that? This is a T1 weighted images. For those of you who don't know, as the CSF here appears dark, the marrow, the bone marrow in the vertebrae, it looks bright. Again, what sequence is that? Look at the screen. This is a T2 weighted imaging. Excellent. How do we know? The CSF here looks bright and the marrow appears a little bit grayish or darker than the T1. Now, let's go to the third question. Guys, look at the screen. Which sequence is that? This is STAIR, or you can call it also T2. FATSAT. Everything is dark except edema and the CSF. Otherwise, the bone marrow is dark, the fat is dark, everything is dark except the CSF and edema. So, to summarize all of this, first, on T1 imaging, the CSF will be dark, the fat will be more whitish, and the cord will be iso-intense. On T2, the water and CSF will be white, while the fat marrow will have intermediate signal intensity, and edema of the cord will be bright, while on STAIR, this water and CSF will be very bright, while the fat will be dark and the edema will be bright. So, again, CSF sequence A, the CSF will be black, the marrow is bright, this is a T1. In sequence B, the CSF is white, the marrow is gray, so this is a T2. And in the third image, everything is dark except edema and CSF, and this is STAIR. You must master these sequences to find any hidden pathology. Let's go to the third case, to the challenge case number 3. It's called the nightmare vertebrae. So let's look at the history. This is a 60-year-old male patient. He's a heavy smoker. He has back pain that keeps him awake at night. He says, "Doctor, the pain is worse when I lie down." That's a red flag. Night pain is the detective's biggest warning sign. Night pain is a bad sign. Now, let's look at his x-ray. Can anybody say what is abnormal? Look at this x-ray of the lumbar spine. What is the name of this sign? Does anybody know? It has a little bit funny name. Is anything abnormal? And if it is, what's the name of the sign? The answer is, the sign is called the winking owl sign. The winking owl sign. You can see this pedicle, this pedicle, this pedicle, and this pedicle, this pedicle. Here, there is nothing. It's like an owl winking at you, making like that. So, excellent. The left pedicle is missing. Now, that's a very dangerous red flag. Let's go to the next clue. It's called the dark marrow on T1. Rule of M of our protocol, the marrow. Look at the T1. The vertebral body should be bright because it contains fatty marrow. But here, it's black. Something has eaten the fat and replaced it with something evil. Look at the pedicles. It's gone. The winking owl on MRI. Look at this pedicle here. It's gone. So this is the winking owl on MRI. Look at the axial images. Look at the T2 fat sat. There are areas of edema here and there involving the pedicles. Guys, detectives, you have all the clue that you need. Is this A, epidural abscess, B, cervical myelopathy, C, spinal metastasis, D, disc extrusion, and E, transverse myelitis or LETM? The correct answer is spinal metastasis. And keep in mind, normal marrow is bright on T1. If it is darker than the disc, then it's infiltrated. Metastasis love the pedicle. There is a love story between metastasis and the vertebral pedicles. Keep in mind that benign hemangiomas are bright on T1. Tumors are dark. So, hemangioma bright on T1, tumors are dark. Are you ready for the third flash round? Flash round number 3. It's called the alignment. Look at the slip. What grade is this? A vertebral body, and this is another vertebral body. What grade is this? Is it grade 1, 2, 3, 4? This is definitely grade 1, in which less than 25% or 1/4 of the vertebra is slipping. This is grade 1 anterolisthesis. Now, look at the second case. Look at the slip. What grade is this? Is it grade 1, 2, 3, or 4? And of course, this is grade 3, which is around 50 to 75% of the vertebra are slipped. And of course, this thing here is longer than this thing, and you can measure it if you are not sure, but this is a grade 3 anterolisthesis. Let's go to the third image. if you can see the fracture in the neck of the Scotty dog, if you can find the fracture of the Scotty dog, and of course, as you can see, this is a good Scotty dog, and this one is a good Scotty dog, while here the neck is broken. This Scotty dog is good, has a good neck, this has a good neck, and here the neck is fractured. So there's a fracture of the neck of a Scotty dog. Just to remind you, the grades of spondylolisthesis, grade 1 is 0 to 25% slip, grade 2 is 26 to 50%, grade 3 is up to 75, and grade 4, it's more than 75% slip. So if the vertebra moves forward 20%, this is a grade 1. Good job. Now let's go to the fourth challenge case. This one is called the liquid threat. Now, this is a 45-year-old female patient. She has a history of IV drug abuse. She has high fever and focal excruciating back pain. She can't let you touch her spine. This is the microbe hunter crossing over into the spine files. You remember the episode of the microbe hunter? Again, she has IV drug use history. She has fever. It's very painful and severely focally tender. Now, let's go to the first sequence, the epidural space. Look at this T2 weighted image of the spine. There is a bright fluid signal in the epidurals and even prevertebral space. What do you think is happening? Look at the epidural collection, the T1 with contrast. We gave the patient contrast. Look at the space behind the vertebral body, but in front of the fecal sac, okay? There is a thick, shaggy rim of enhancement here. There is a rim of enhancement, thick and shaggy, with a liquid center. It's compressing the fecal sac. This is a surgical emergency. Is it epidural abscess? A, B, cervical myelopathy, C, spinal metastasis, D, disc extrusion, or E, transverse myelitis. Of course, it is epidural abscess. Keep in mind, fever plus focal pain plus IV drug use means abscess until proven otherwise. This is often paired with discitis and osteomyelitis. We call it spondylodiscitis. Always look for the pus in the epidural space, okay? And the last case is called the slow squeeze. The slow squeeze. Now, let's see what's wrong here. Our last case, a 70-year-old male patient, he says his hands feel clumsy. He can't button his shirt anymore. When he walks, he feels unsteady. No sudden pain, just slow fading of his strength, okay? Clumsy hands, difficult with his buttoning, and frequent falls. There's electrical shock down the arms called Lermit sign. Now let's look at the clue. The first clue, it's called the pancake sign, T2 sagittal. There is a bright spot in the cord on T2. Look at the cervical cord. Look at C5-6 level. The canal is tiny because of a big disc protrusion. Let's see, 2, 3, 4, 5, 6 here. We have a disc protrusion and the canal is tiny. Now, let's go to the second clue. It's called the pancake sign. The disc is not round anymore. It's flattened. It's like a pancake. And look inside. There is a bright T2 owl eye signal. The cord is scarred. You can see here the owl eye signal. And on T1 weighted image with contrast, this is a T1 with contrast, T1 with contrast, you can see some enhancement here. And you can see this bright spot on the T1 fat saturated image. There is a chronic compression leading to irreversible scatter. We call it the pancake sign. You have all the clues that you need. Come on, detectives. Is it epidural abscess A, B, spinal metastasis, C, cervical myelopathy, D, disc extrusion, or E, transverse myelitis? And the correct answer is, of course, cervical myelopathy. Myelomalacia due to chronic spondylotic stenosis appears bright T2 on T2 weighted imaging means that the wires or the tracts of the spinal cord are frayed, are damaged. So this is as cervical spondylotic myelopathy. Keep in mind that chronic pressure will kill the cord slowly. Once you see that bright T2 signal or myelomalacia, the damage most likely is permanent. So you have to decompress them early before any irreversible damage has happened. So let's have a summary of the spine files. Disc extrusion, you have to see a narrow neck, metastasis, you have to see a dark T1 bone marrow signal, abscess, there's fever and edema at the disc and the vertebrae and the prevertebral and the epidural spaces with rim enhancement. Myelopathy, look for the pancake cord. And Keep in mind that disc exclusion will present with acute pain, myelitis will cause paralysis, metastasis usually have a subacute presentation or night pain, while abscess, it is an acute emergency. So, the episode 6, the spine files, has been decoded. We solved the spine files. We are becoming masters of visual patterns recognition. Keep in mind that to sharpen your eyes for the next challenge, make sure to subscribe, share, and hit that bell button. Welcome back, detectives. Today, the clock is our biggest enemy. We are opening episode 7, called the trauma files. When the head meets impact, the brain doesn't just bruise. It shifts, it bleeds, and it fights for space. We are hunting for the red flags of impact. So let's start the clock. First of all, the trauma protocol. To survive the trauma bay, you need a protocol. Rule number 1, check the shape. Blood tells you which vessel broke by how it flows. Rule number 2, check the midline. If the brain is shifting, the patient is dying. Rule number 3, when the CT looks normal but the patient is comatose, go to MRI, SWI or susceptibility weighted imaging. The truth is in the microbleeds. Again, look for the shape. Is it lens? Is it crescent? Or the geometry of the hemorrhage? Look for midline shift. Is the midline where it belongs? Is there any mass effect? And look for SWI or susceptibility weighted imaging in MRI to look for any hidden black dots which might indicate diffuse axonal injury. So let's meet our suspects for today. The suspect lineup will be epidural hematoma, subdural hematoma, subarachnoid hemorrhage, diffuse axonal injury, and brain herniation. This is today's lineup. From the classic lens of the epidural hematoma to the invisible damage of diffuse axonal injury, 5 suspects, 1 mission, prevent secondary brain injury. Let's go to challenge case number 1. It's called the lucid interval. Now, case number 1 is a 20-year-old soccer player or football player takes a blow to the temple. He passes out for a minute, wakes up feeling fine, then an hour later, he's in coma. The classic lucid interval. So let's look at the scan. The first clue, it's called the biconvex lens. Look at this shape. It's a lens. This is a lens, okay? Why? Because the blood is trapped between the bone here and the dura here. It's trapped, okay? So the dura is stuck at the sutures here and here, the sutures. So the blood can't spray. It's high pressure, usually from an artery, the middle meningeal artery. This is a surgical now case. This is a surgical emergency. What's this case? Is it A, diffuse axonal injury, B, subdural hemorrhage, C, subarachnoid hemorrhage, D, epidural hemorrhage, E, brain herniation? What is the case? Case number 1 is epidural hematoma. Remember, the lens that does not cross a suture, if you see this, the neurosurgeon is the patient's only hope. Call the neurosurgeon immediately. Now, are you ready for flash round number 1? The flash round, it's called the shape match. What is the shape here? And what is it? What's the shape and what is it? This is a biconvex or lens shape, and this, as we said, represents epidural hematoma. Okay, and of course, subglial hematoma also is seen here. Lens-shaped hematoma means epidural hematoma, and it is arterial blood. So again, epidural here and subglial here. Of course, the subglial is secondary in this condition. The epidural is the main pathology. Again, what's the shape here and what does it represent? This is crescent shape, and crescent shape indicates subdural hematoma, and subdural hematoma is different in that it crosses the sutures, but it does not cross compartments. Keep that in mind, and it's venous blood. So epidural versus subdural, never ever mix them up. You cannot make a mistake here. Let's go to challenge case number 2. It's called the crescent moon. Now, case number 2 is an 80-year-old male on blood thinners, fall at home. 2 days later, he's sleepy, he's confused. No pop, just a slow drift into the darkness, slightly gradually going into the darkness. So the clue number 1, it's called crossing sutures. This blood is different from the previous case. It's crescent. It's spread freely because it's under the dura. It crosses sutures but stops at the falx. This is venous blood. It's low pressure but deadly mass effect over time. So this is a crescentic shape that does not cross compartment. It does not go to the other side or to the infratentorial. Okay, it's limited to one compartment but crosses the suture. What is your vote? Is it A, subarachnoid hemorrhage, B, subdural hemorrhage, C, diffuse axonal injury, D, epidural hematoma, and E, herniation? It is a subdural hematoma, the crescent of the elderly. It's usually in elder population due to the brain atrophy that happens there, and the anticoagulation I give you in the history. So check for any bridging veins to confirm. But again, this is a crescentic shape of subdural hematoma. Are you ready for flash round number 2? Flash round number 2 called the density check, acute versus chronic. Is this an acute, subacute, or chronic hematoma? This is a subdural hematoma. It's crescentic shape. It spreads over the hemisphere. It crosses the sutures. It does not cross to the other side, doesn't go through different compartments. But is it acute, subacute, or chronic? This is chronic subdural hematoma because it's of low density. The density here is dark, slightly more than the CSF, but it's hypodense, indicating long-standing hematoma. This is just the seroma, let's say. It's the plasma of the blood, while the RBCs are being collapsed and probably absorbed. Again, is it acute, subacute, or chronic hematoma? What do you think here? This is again another subdural hematoma all over the cerebral hemisphere, and it's causing mass effect. Again, it's causing midline shift to the opposite side. This is very serious, very dangerous. This is dense. Dense means fresh blood, means acute, and this is a very serious type of subdural hemorrhage. Again, it's causing midline shift, and it's acute, indicating it might go larger. Acute, subacute, or chronic hematoma? Can you find it, and can you know the age? Acute, subacute, or chronic? Look here. This is the midline. There's a brain shift to the other side. There's compression of the ventricle. This is a very tricky type of hematoma. Why? This is a subacute subdural hematoma. When the blood density gets lower, there is a stage at which the density of the blood is almost the same as that of the brain. And that is why you have to be very careful not to miss it. It's difficult, but it's very important. Again, quick check. If the blood is bright white on CT scan, it's fresh, it's acute. If it is as dark as water almost, it's old. And now, if it is isodense to the brain, it's difficult to be seen. You need to be careful about that. It's subacute. This tells the surgeon how long the brain has been under pressure. And this is a very important finding. Now, let's go to challenge case number 3. It's called the invisible trauma. Now, this is a high-speed car crash. The CT scan looks boring. Maybe tiny dot of blood here or there, but the patient has a Glasgow coma scale of 3. He's comatose. Why does the clean scan lie to us? Let's see the clue number 1. It's called the boring CT scan. Look here. There is nothing, probably some tiny spot of blood here, maybe some tiny blood spot here. What sequence of MRI would you like? Go to susceptibility weighted imaging or SWI. Now, we switch to MRI, specifically SWI. Look at the black dots at the gray-white matter junction, okay? The brain is sheared during the crash. The axons are torn. This is why the CT looks normal, but the patient isn't waking up. Look at these tiny dots here, here, here. And look here. Look at the corpus callosum. Look even at the midbrain. There are multiple tiny dots. You can see them on SWI. Is it A, diffuse axonal injury, B, subdural hemorrhage, C, subarachnoid hemorrhage, D, epidural hemorrhage, or E, herniation? And the correct answer is diffuse axonal injury. The clinical radiologic mismatch is important. The high velocity microhemorrhage, poor prognosis. The black dots tell the real story, usually at the sites where the brain parenchyma meets white matter, the gray matter meets white matter, and at the corpus callosum, and even in the brain stem. So keep that in mind. Now, let's go to the next flash round. It's called the location hunt. Where is the diffuse axonal injury? Look here. Which location is the most severe? Is it 1, 2, or 3? Is it the microbleed at the gray-white matter junction? Is it the microbleed in the corpus callosum? Or is it the microbleed in the brainstem? Although it's the smallest microbleed, but brainstem microbleed, it's very dangerous. Brainstem involvement is the most critical stage of diffuse axonal injury. Let's go to challenge case number 4. It's called the severe headache. Now, this is a motorcycle accident. Patient presented with severe accident. He said it's the worst headache he had in his entire life. Now, clue number one, call the star of the cell site. Look at the star pattern, okay? In the cisterns, in the white lines in the cell site. Look here, okay? This is subarachnoid blood. In trauma, it's usually at the site of impact. If it is only in the basal cistern without trauma, think aneurysm. But if it's trauma and it's in the basal cistern, you have to tell me, is it A, diffuse axonal injury, B, subdural hemorrhage, C, subarachnoid hemorrhage, D, epidural hemorrhage, or E, herniation? The answer, the reveal is traumatic subarachnoid hemorrhage. Motorcycle accident, severe headache, the blood isn't a lens, it's not a crescent, it's everywhere, literally, this is all blood. And traumatic subarachnoid hemorrhage, the most common type of bleeding, it follows the grooves of the brain like water in a canyon. It falls all over. Now, let's go to the final case and the challenge case number 5. It's called the final alarm. Focus here. Last case, the patient with a massive bleed, intracranial bleeding. Suddenly, one pupil is fixed and dilated. This is the end stage of the mass effect. We are looking for the push. Again, patient with massive bleed and one pupil is fixed and dilated. Clue number 1, the blown pupil. You can see this pupil is widely dilated while this pupil is normal size. Now, let's go to clue number 2. It's called the midline shift. Look at the midline. It's shifted more than 10 millimeters. The midline is shifted here. The temporal lobe or the uncus, this one here, is being pushed down by this bleed, okay? This is our problem. It's compressing here, it compresses the third nerve, the oculomotor nerve, the third nerve pulse, and that's why the pupil is blown. This is the final alarm for this brain. Is it diffuse axonal injury? Is it subdural hemorrhage? Is it subarachnoid hemorrhage? Is it epidural hemorrhage or herniation? It's E or herniation. Now, my next question, what type of herniation is causing the patient's blown pupil? There are two types of herniation in this case. I will not tell you what are they. Which one of them is causing the blown pupil? It is uncal herniation. Uncal herniation is perfectly true. Now, what other herniation is also present? What other type of herniation is present in the same case? So this case has uncal herniation, and this is an uncal herniation due to the mass effect. You can see the uncus is herniated here, compressing the third cranial nerve or the oculomotor nerve, and it's causing the dilated or blown pupil. The ultimate consequence of untreated trauma, we don't just look at the blood, we look at what the blood is doing to the neighborhood. Again, the other type of herniation is subfalcine herniation, the brain, or basically the midline herniation. The brain is herniating under the falx to the other side, but this is what's causing the blown pupil. So the final cheat here is, look, this is your trauma pocket guide. Lens versus crescent, shear versus groove. Master this and you master the trauma bay. Epidural hematoma, it's lens and it's an artery. Subdural hematoma, it's crescent shape and it's venous blood or vein. Diffuse axonal injury, it's dots on SWI or MRI, and subarachnoid hemorrhages is going into the sulci and the groove. So episode 7 is closed. We hunted the shape, the shift, and the dots. Trauma is fast, but your eyes are now faster. Stay sharp, stay safe. Don't forget, like, subscribe, share, tell your friends about us, and support us. Welcome back, detectives. Now we have navigated the spine and survived the trauma bay. But today, we face our most delicate challenge yet. Little brains don't just have smaller versions of adult problems, they have their own developmental secrets. So welcome to episode 8, the pediatric files. Let's start hunting. First of all, before we open the first file, you need the pediatric roadmap. I call it the ASM protocol. Rule for kids. A is anatomy. Is it fully formed? S is for symmetry. Does the left side mirror the right side, or there is any difference? And M is for the myelination. Is the brain on schedule for its age? If you don't know the schedule, you'll miss the crime. So keep it in mind. A is for the anatomy, S is for the symmetry, and M is for the myelination. Okay? Keep that in mind. Now, the rules for detecting a crime. Rule number 1, look at the vermis for posterior fossa cases. Rule number 2, asymmetry in a child is a red flag for migrational disorders. And rule number 3, know the T1 and the T2 myelination milestones. If you don't know what's normal for a 6-month-old child or infant, you'll misdiagnose a healthy baby as sick. So you have to know these. Rule number 1, look at the vermis. Rule number 2, asymmetry in a child is a red flag. And rule number 3, know the T1 and the T2 myelination milestones. Okay? So, the suspect lineup. Today we will see these suspects and we'll know how to differentiate between them and how to diagnose them. Let's go to challenge case number 1. It's called the vermis hunter. The presentation is an infant whose head is growing way too fast. The fontanelle is bulging. The back of the head looks prominent. This isn't just simple hydrocephalus. Something is structurally wrong. Let's look at the midline. Now, look at the sagittal T1. This here. The posterior fossa is massive. Looks like a giant balloon. But look at the cerebellar vermis. Okay? It's absent. And look at the torcula. Here, the torcula. It's way too high. We call this the torcular lambdoid inversion. Usually, the torcula should be below the lambdoid suture. Now it's above the lambdoid suture. So, torcular lambdoid inversion. The fourth ventricle has become a giant cyst. What do you think this is? A. Medulloblastoma. B. Holoprosencephaly. C. Adrenoleukodystrophy. D. Neurofibromatosis type 1. And E. Dandy-Walker malformation. The case is a E or Dandy-Walker malformation. So this is a classic Dandy-Walker malformation. Pearl. It's a triad of hypoplastic vermis, large posterior fossa, and a cystic fourth ventricle. If the vermis is normal, you're just looking at a megacisterna magna. So be a detective, find the vermis. If a normal vermis, it's a megacisterna magna, nothing else there. Let's start with the flash round number 1. Flash round number 1 called the milestones. Quick fire. At what age does a child brain looks like an adult brain on T1? What age? Well, the correct answer is the child's brain starts to look as an adult on T1 at around 6 to 8 months. So anything between 6 to 8, you're right. Let's go to the question 2. At what age does a child's brain look like an adult on T2? The correct answer is around 2 years or 24 months. On T2, it starts to look like an adult brain. Now, next question. True or false? Myelination starts at the front and moves back. Of course, the answer is false. It starts at the back and moves to the front, and it starts at the center and moves to the periphery. Okay? Back to front and center to periphery. Let's go to challenge case number 2. It's called the calcified ring. Now, the presentation is case number 2 is a newborn baby with microcephaly. They failed their hearing screen test in the nursery. We need a CT to look for the scars of prenatal crime. Is this a torch infection hunt? Let's see. Clue number 1. It's called the periventricular hunt. Look at these bright white dots on the CT scan. Here and here and here. They are calcifications, but look at their location. They are perfectly hugging the walls of the ventricles. They are periventricular in distribution. If they were in the basal ganglia or in the cortex, we'd think toxoplasmosis. But here, at the periventricular distribution, the suspect has a very specific fingerprint. Now, the correct answer is A. Medulloblastoma. B. CMV infection. C. Adrenoleukodystrophy. D. Septo-optic dysplasia. And E. Dandy-Walker malformation. And of course, the answer is congenital CMV infection. This is a congenital CMV. Keep in mind that periventricular calcifications in an infant equals CMV. It's the most common congenital infection. It destroys the brain early, leading to microcephaly and that silent hearing loss. Find the calcium, find the case. It's called the butterfly wing. Case 3 is a 7-year-old boy. He has a straight He was a straight student, straight A student, but now he's failing school. His vision is fading and his behavior is becoming aggressive. This is a progressive neurological decline. Let's go to clue 1. Clue 1, it's called the posterior spread. Look at this T2 weighted image. The white matter in the back, the parieto-occipital region, is glowing. It spreads across the splenium of the corpus callosum to involve both cerebral hemispheres, like a symmetric butterfly wings. If you look carefully, there is a thin, dark leading edge of active destruction, just right here and right here. Very thin, dark leading edge of active destruction. This is a white matter nightmare. Can you guess who's the criminal? Is it A, medulloblastoma, B, CNV infection, C, adrenoleukodystrophy, D, neurofibromatosis type 1, and E, thalamic hamartoma? The reveal, the suspect is adrenoleukodystrophy. This is an X-linked disease. It's adrenoleukodystrophy. Pearl, it's a metabolic disorder that kills the myelin from back to front. If you see symmetric posterior white matter disease in a young boy, adrenoleukodystrophy is your prime suspect. What test you do to confirm? Test the very long chain fatty acids. Very long chain fatty acid, VLFA, okay? Good. Let's go to flash round number 2. It's called the masquerade, okay? We'll talk about the fourth ventricle tumors. Now, 3 tumors in the fourth ventricle. The one that is dense in the midline, this is a tumor that's dense in the midline. What is it? Dense fourth ventricular tumor in the midline is medulloblastoma. Let's go to the second question. The plastic one that squeezes through the holes. You can see it's squeezing through the exit foramina of Luschka and Magendie. It's plastic fourth ventricular tumor. What is it? This is an ependymoma. It's plastic, it squeezes through the exit foramina. Let's go to the third tumor. This is a cyst with a bright nodule. What is it? Fourth ventricular tumor, a cyst with a nodule. It's a pilocytic astrocytoma. Hemangioblastoma is a possible differential diagnosis. However, it's usually hyperintense. The nodule is hyperintense on post-contrast images. Okay, pilocytic astrocytoma is way more common than hemangioblastoma. Okay, so the texture tells everything. The one that's dense in the midline, it's a medulloblastoma. The plastic one that squeezes through foramina is an ependymoma, and the cyst with a bright nodule is a pilocytic astrocytoma. Excellent. Now, let's go to challenge case number 4. It's called the cellular hammer. Now, what's the presentation? This is a 5-year-old child with morning headache, projectile vomiting. They are walking like they are drunk or ataxia. We find a mass in the midline of the cerebellum. Now, let's go to clue number 1. It's called the MRI. And this is clue number 1. Look at the mass. It's solid, it's at the midline, it's probably iso-intense to the surrounding cerebellum on T2, and on T1 it's hypo-intense. Now, let's go to clue number 2. What is the next thing that you want to do and to see on clue number 2? What do we need to do? We need to do a diffusion weighted imaging. And this is the diffusion weighted imaging. This is the key to the answer. It glows white on diffusion and it's hypo-intense on ADC map. Okay, this means it's hypercellular. It's composed of a lot of cells. The cells are packed so tight that the water can't move. Its diffusion is restricted. Now let's go to clue number 3. It's called the CT scan. On a CT scan, the mass would be bright white. It's composed of dense packed cells. It's white or hyperdense on CT scan. You have all the clues. Is it A, medulloblastoma, B, septo-optic dysplasia, C, adrenoleukodystrophy, D, neurofibromatosis type 1, and E, pilocytic astrocytoma? The answer is medulloblastoma. This is the most common malignant brain tumor in kids because it's so cellular, it restricts diffusion. And remember, always scan the spine to find the drop metastasis. Always scan the spine. Let's go to flash round number 3. It's called the midline. Steer horn ventricles. What is the diagnosis? You have steer horn ventricles. What is the diagnosis? The ventricles are just parallel to each other instead of being the usual shape. This is diagnostic of corpus callosum agenesis. The corpus callosum, it's absent, or also called the racing car sign. You are completely correct. Absent corpus callosum or corpus callosum agenesis. Next slide. Let's see. Single large ventricle like a pancake. Single ventricle large like a pancake. The answer of single large ventricle like a pancake is holoprosencephaly. The third midline problem, a missing septum pellucidum. The septum pellucidum, which should be here, is missing. It's not there. What's the diagnosis? The answer is septo-optic dysplasia. Septo-optic dysplasia. So keep in mind, agenesis of the corpus callosum has the racing car sign or steer horn ventricles. Holoprosencephaly is a single large ventricle like a pancake, and septo-optic dysplasia is a missing septum pellucidum. So the midline is the mirror of development. Let's go to the final challenge case for today's episode. Challenge case number 5. It's called the bright objects. The presentation of our final case is a child with cafe au lait skin spots. We are doing a screening MRI. We find a little bright spots, but the child has no symptoms. So is it a tumor, or it's just an artifact or quirk or whatever? Clue number 1, they call the globus pallidus. Look at the T2 and the flare. These are the T2 signals and sequences and the flare sequences. These tiny bright spots in the globus pallidus here, you can see it more obviously in the flare. And at the cerebellum, you can see also some few tiny bright spots here and there. So we have tiny bright spots. Look closely. There is no mass effect. They don't push anything. Now, let's go to the post-contrast images. This is the T1 post-contrast. They don't enhance with contrast. We call them foci or focal areas of signal intensity. Okay, you have all the clues that you need. Is it A, pilocytic astrocytoma, B, encephalitis, C, adrenoleukodystrophy, D, neurofibromatosis 1, and E, thalamic hamartoma? So the reveal for this case, the answer is, of course, neurofibromatosis type 1. These are unidentified bright objects, the white spots. They are benign echoes of development. They often vanish as the child grows. Don't biopsy them and don't panic. Just follow them. Just follow the brain. Okay? They are called unidentified bright objects. So, the pediatric files are closed. You navigated the growing brain with precision. Stay ready. And don't forget, like, subscribe, share, tell your friends about us, and keep coming, keep commenting, and keep watching, keep studying. I am Dr. Ahmed D. Abdulwahab. Stay safe, stay happy, never forget to smile. Good evening, everyone. Welcome back, detectives. We have navigated the spine, survived the trauma bay, and unraveled the delicate mysteries of childhood. But today, in this last episode of the Brain Radiology Detective series, we confront our fastest enemies. In episode 9, we will confront the vascular villains. In the cerebral vascular map, a single second of a blockage or rupture changes everything. So let's hunt. First, let's start with the vascular protocol. Before we crack the first case, we must align our tools. We adapt our classic ASM protocol for the vessels. A is for the arterial flow. Look for the cutoff. Shift and swelling, the S. Evaluate the parenchymal distress. And for the M, we have the malformations. Hunt for abnormal nests, bags, and balloons. This is our checklist for every case. A for the arterial flow, the location and the cutoff. S is for the shift and swelling, the parenchymal distress, and M is for any malformations like nests, bags, and balloons. The commandment rules, the most important rules here. Rule number 1, time is brain. Know your hyperacute stroke signatures. Rule number 2, blood in the basal cisterns is a ruptured aneurysm until proven otherwise. Rule number 3, do not mistake a dural sinus clot for a simple parenchymal hemorrhage. Watch the venous channels. Rule number 1, time is brain. Rule number 2, blood in the basal cisterns is a ruptured aneurysm until proven otherwise. And rule number 3, do not mistake a dural sinus clot for a simple parenchymal hemorrhage. Keep these in mind. Are you ready for challenge case number 1? Let's start with challenge case number 1. It's called the hyperacute threat. Now, the presentation. Our first case, a 62-year-old female presents with sudden onset left-sided weakness and slurred speech. Onset was exactly 45 minutes ago. The clock is frozen and we need to locate the block. Clue number 1 is the diffusion-weighted imaging and the flare mismatch signature. Look at the axial diffusion-weighted imaging scans. There is an unmistakable bright white signal in the right MCA territory. This is it. And on the ADC, it looks hypointense, indicating acute ischemic stroke. But on the corresponding flare sequence, the brain parenchyma looks relatively normal. There's nothing here. This is what we call diffusion-weighted imaging flare mismatch, our absolute proof of hyperacute tissue that can still be saved. What's the diagnosis? Is it an acute ischemic stroke, moya-moya disease, aneurysm, AVM, or venous sinus thrombosis? And the reveal is, of course, A, an acute ischemic stroke with hyperacute MCA occlusion. It's a hyperacute right middle cerebral artery ischemic stroke. Time is brain. And this mismatch means we are well within the window for thrombolysis and thrombectomy. So this is a very important thing to notice. There is a mismatch. The flare looks normal or relatively normal, and the diffusion showing diffusion restriction, indicating there's time for saving the brain. It's not dead yet. Are you ready for flash round number 1? Flash round number 1, it's called the stroke mechanics. Ischemia versus hemorrhage. On a non-contrast CT, blood appears bright or dark. Blood appears bright white on non-contrast CT. Now, question number 2, quick fire challenge. On diffusion-weighted imaging, ischemia appear as bright or dark? The answer is ischemia glows bright white on diffusion-weighted imaging. Know your sequence, know your substrate. Okay, good. Quick fire. Again, which one is more sensitive to acute ischemic stroke, CT or MRI? Which one is more sensitive? Which one turns positive faster? Of course, the answer is diffusion-weighted imaging. It's much more sensitive than CT scan. And diffusion-weighted imaging, there has been some reports that it turns positive few minutes after the onset of stroke. Okay, while CT scan takes hours to be positive. So diffusion-weighted imaging, specifically on MRI, is very, very sensitive to acute ischemic stroke. Let's go to challenge case number 2. It's called the ruptured bomb. Now, for the case presentation, case 2 is a 45-year-old male, describes the worst headache of my life with a sudden thunderclap explosion of pain during physical exertion. He collapsed on arrival. Now, for clue number 1, look at the CT. The subarachnoid space is completely flooded with hyperdense blood. Okay, this is the star-shaped increased density. It's completely flooded with hyperdense blood. Now, let's go to clue number 2. It's called the CT angio or the CTA. Look at the CTA of the circle of Willis. Right at the anterior communicating artery, just right here, and right here. Okay, there is a focal berry-like sac ballooning outward. This is a vascular bomb that has gone off. And as I told you, basal cisterns filled with blood is what, until proven otherwise, is it? A, venous sinus thrombosis, B, moya-moya, C, AVM, D, acute ischemic stroke, or E, aneurysm. The reveal is a ruptured anterior communicating artery berry aneurysm, causing devastating subarachnoid hemorrhage. And here, off to the coiling suit, to the interventional radiology suit immediately, because this is fatal if not treated perfectly. Let's go to flash round number 2. It's called the vascular territory mapping. Quick fire. Question 1. Which territory controls the legs? Is it ACA, anterior cerebral artery, middle cerebral artery, or posterior cerebral artery territories? Which territory controls the legs? ACA, MCA, or PCA? And of course, the answer is anterior cerebral artery territory. Which territory controls the face and arms? Is it ACA, MCA, or PCA? And the answer is the middle cerebral artery territory. Again, spatial neuromapping. Which territory controls the vision? Is it ACA, MCA, or PCA? The correct answer is the posterior cerebral artery or the PCA territory. So, the lesson from this one is map the deficit to the vessel. Let's go for challenge case number 3. It's called the serpentine nest. This is a 28-year-old female presents with recurrent seizures. 28-year-old female presenting with recurrent unexplained seizures. Clue number 1, the CT scan. Her CT shows calcified squiggles, but we need an MRI to see the dynamic culprit. You can see few foci of calcification here, few foci of calcification here, and here It's not very interesting, but we need the MRI to see what's going on there in details. So let's go to clue number 2, the MRI. Look at this T2 weighted MRI. There is no normal brain parenchyma here or here or here. Instead, we see a chaotic cluster of dark serpentine structures, classic flow voids. They look like a bag of black worms. This is a high velocity blood shunting directly from arteries to veins without a capillary bed. So, what is it? Is it A, moya, B, venous sinus thrombosis, C, aneurysm, D, acute ischemic stroke, or E, AVM? The reveal for this case is E, or cerebral arteriovenous malformation, or AVM. It's a classic cerebral AVM. The nidus is fed by a dilated MCA branches and drains directly into the dural sinuses. It's a ticking hemodynamic clock. It might rupture and cause a massive bleed at any minute. So, are you ready for flash round number 3? It's called the angiographic signatures. Quick fire. First question. The dark triangle on CT with no contrast. What is it? What is the name of the sign of this dark triangle on CT with no contrast? The answer is empty delta sign. This is a thrombus within the superior sagittal sinus. You can see it here and here, and that's what we call empty delta sign. Question number 2, pattern recognition. What is the hazy network of tiny basal collaterals? What is the name of the sign? This tiny basal collaterals. It's a hazy network. What do we call this sign? The answer is a puff of smoke. This is called a puff of smoke. Multiple dilated collaterals at the basal basal ganglia of the brain. So, are you ready for challenge case number 4? It's called the closed drain. The presentation for challenge case 4 is a 32-year-old postpartum female on oral contraceptives, presents with severe progressive headaches and papilledema. Her arterial system looks normal. So, clue number 1, it's called the central filling defect. Look at this contrast-enhanced CT venogram at the posterior superior sagittal sinus. Look here. We see a classic empty delta sign. The sinus walls enhance with contrast, but the clot inside remains completely dark. You see the clot here? It's dark with contrast flowing on the sides of it, of the sinus. A central filling defect. This venous drain is locked, clogged, obstructed, occluded. These are all the clues that you will have. What is it? A, moya, B, venous sinus thrombosis, C, aneurysm, D, acute ischemic stroke, or E, AVM. And of course, the reveal is a dural venous sinus thrombosis of the superior sagittal sinus. High intracranial pressure from venous congestion is the result. So anticoagulation is the key to reopening the drain. Now, for our last case of this series, challenge case number 5, it's called the fragile storm. Now, our final case is a 9-year-old girl presenting with progressive transient hemiparesis provoked by crying or blowing on hot soup. Let's look at the MR angio and the digital subtraction angiography of this poor girl. Look at this terminal internal carotid artery. Look here and look here. It has narrowed down to a tiny thread, but around the base of the brain, we see a massive, hazy cloud of abnormal collateral vessels. It looks exactly like a puff of smoke rising from the chimney. This is the brain's desperate attempt to bypass the blockade. Look at the MRA here and here. Look at the digital subtraction angiography on the left and right side. Now, these are all the clues that you will have. Is it A, moya, B, venous sinus thrombosis, C, aneurysm, D, acute ischemic stroke, and E, AVM? The reveal for this case is moya disease. It's a progressive bilateral stenosis of the supraclinoid internal carotid arteries. These fragile, hazy vessels are highly prone to microaneurysms and hemorrhagic rupture in adults and ischemic stroke in children. So, the vascular cheat sheet, keep in mind, MCA stroke, there will be DWI or diffusion weighted imaging mismatch. Aneurysm, there will be perianeurysm or causing subarachnoid hemorrhage. AVM we will see flow voids, serpentine in nature. The cerebral venous sinus thrombosis will see empty delta sign. Moya moya will see puff of smoke. Again, there's your vascular valence pocket guide. MCA stroke, diffusion weighted imaging mismatch, aneurysm, peri or subarachnoid hemorrhage. AVM, flow voids, serpentine, and venous sinus thrombosis will see empty delta sign, and moya moya will see puff of smoke. File this away in your diagnostic database. So, episode 9 is closed. This part of the radiology, the brain radiology, is closed. You hunted down the blockades, the ruptures, and the shunts with absolute diagnostic speed. Keep your eyes sharp and your reflexes faster. Don't forget, like, subscribe, share, and tell your friends about us. And never ever forget to smile. Keep your eyes sharp, stay safe. Thank you very much, and good night. Thank you. Bye-bye.